So we were founded in 2009 by Dr. Durga G. Rao and Mr. Kiran Gadela. In fact, Dr. Durga would be joining us in some times. We are an ICMR registered organization. Just to keep you posted here, that in India currently there are about 3,500 fertility clinics which are operational, and out of which only about 500, probably 550 are just recognized by ICMR, and we are one of them. A lot of laurels to us in terms of we have been selected as power brand for 2018, 19, 20, and 21 by IVF India. We are recipient of Best Healthcare Asian Award for the year 2019 as well as 20 from the Economic Times Group, and we have been one of the number one player in South India as well as Hyderabad, and number three player in across the country today. So these are our two co-founders. Both decided to come back to India. Dr. Durga was practicing in UK. She did her fellowship in Canada, and for about 10 years she was in UK. And then Kiran was a banker. He was also in UK. Both decided to come back in 2009 and do something for the country here. So that's how the genesis of Oasis began, as one single center in the city of Hyderabad, Banjara Hills. We have this core team member, clinical team of both Dr. Durga as well as Dr. Krishna. In fact, Dr. Krishna is also going to speak. He's our he's our scientific head and clinical embryologist. And he's the alumni of Monash, one of the prestigious institute for embryology today. Well, this slide talks about the entire journey of Oasis. Currently, we operate about 18 centers across the country, and also as we speak, 7 more of our centers in another one in Bangalore, another one in Mangalore. Then we have Karnool, Karimnagar, Ongole, and Bhubaneswar and Elluru coming up in next 2 to 3 months' time. So by this financial year end, we will be a 25 center organization. So this is our footprints in the country as of today. Well, we have been adjusted as 50 high growth companies in India, as well as I told you, we are number one in South India. In terms of patient centricity, we are very, very sensitive to the to the patients. We are extremely careful about how we deal with the patients. That's the reason why today we have this score of about 4.9 over 5 in terms of our entire the reviews which we get from the patients today. We are leading the IVF space in terms of the number of IVF cycles. So far, I think about 10,000 IVF cycles, 15,000 IUI cycles. And we have got about close to 40,000 happy families whom we have treated. We have a collective experience of almost about 300 years. When I talk about collective experience, it's all about the experience which is put in by our clinicians. All of our centers are primarily, we have full-fledged labs. We don't do batching at all. Every center of ours would have at least embryology team, at least 1 or 2 embryologists. And we have success rates which are quite above the benchmark, the global standards primarily. I think for us, quality is the key, very, very close to our heart. There is no compromise at all as far as quality is concerned. And glad to share that out of, I think there are in India about only 2 or 3 organizations which are NABS certified, and we are one of them. We are also a member of ASRM and FOXY, and as I told you, we stringently follow ICMR guidelines. In fact, being self-regulated is the key, though there are a lot of very, very loose ends in terms of the regulations around the IVF clinics, but we believe that we should be self-regulated. In terms of all our labs, we have state-of-the-art labs in all of our IVF centers. We have a class 10,000 environment and a total quality management system in place. All our consumables used for embryo culturing are MEA tested for toxicity. This is one of the global standards as far as the embryology consumables are concerned. And we don't operate any of our labs without an AHU. Right? And all our microscopes are attached with cameras, and procedures are witnessed by at least 2 people, so that there is no mix-up of gametes which are happening. And all the samples are given unique IDs. So these are the spectrum of services right from, I think, basic IUIs, IVS, everybody does, but I think I would like to draw your attention to a couple of things here. One is PGT and PGTM or PGT or ERA primarily. In terms of the numbers, today we are number 2 in the country as far as pre-genetic screening is concerned. The number of samples which we do across the country, we are the highest, right? And in terms of our in vitro maturation, I think nobody does that. Very, very few clinics does that. And in fact, Dr. Durga is the only lady in Asia who has submitted a lot of papers, research papers in IVM. Electronic witnessing system, I'm sure you will understand that it's a track and trace mechanism, and this particular technology actually gives the entire confidence to the patient that there is no mix-up of the gametes which are happening in the lab, and the patient is ensured, or the patient is kind of given the hope that it's going to be their own genetic child or a biological child, right? Well, our success rate across all the board, much above the global standards. I just told you about our PGT. I just spoke about the IVMs, and I would like to draw your attention on this slide in terms of vitrification and fertility preservation. We all know that vitrification and fertility preservation actually decreases the treatment cost, as well as the success rate is actually up using this technology. But what is important here to understand today is that two aspects. One is the clinical fertility preservation. A lot of cancer patients, young cancer patients, who deserve to be parents, we actually help them. In fact, glad to share that I think we have close to about 350 to 400 patients, cancer patients, whose gametes are preserved with us, and very soon they can, start the dream of their parenthood. I'm sure you'll understand that in terms of cancer treatment, it is important for them to, before they start the cancer treatment, before they start maybe the radiation therapy or chemotherapy, it's important that they preserve the gametes, and we have exclusive bank where they freeze their gametes. The second trend is nowadays social freezing, where a lot of young females, both married, unmarried, they actually preserve their oocytes with us. So from that perspective, vitrification and fertility preservation becomes extremely important, and that's one of our core work which we do at Oasis Fertility. Well, Artis is one of our information system. This is the platform which we use. The beauty of this particular platform is that right from the first call which the patient makes till the patient is actually conceived, the entire journey of the patient is tracked in Artis. And this we have built over a period of last 10 years. It is indigenously built, and then it's one of the fantastic tools which we use. This actually facilitates a lot of AI in terms of IVF. I'm sure Dr. Krishna is going to speak more about AI today in his session. Well, you'll all agree with me today that fertility is just not women's prerogative. 50% of it is actually contributed by male factor also. So that's the reason why every fertility clinic or every Oasis Fertility Clinic is actually operating Andro Life Clinic, which is an exclusive male fertility clinic which deals with the male issues. I just spoke about the fertility preservation aspect. We have this, entire system is called ReproBank, where we preserve the, fertility of patients. Well, I think we have been very, very resilient during COVID time. I think COVID has taught us a lot of lessons. The same was with us. We quickly learned the lessons, and then we were very resilient in terms of, coming back or bouncing back. And we kind of applied stringent COVID protocols at our center. These are some of the snapshots of how we deal with the patients. For us, I think patient safety is very, very prime and important. During that phase, we saw you quickly got into online mode, and then we were giving online consultations to patients. Even now, it is actually continued. We had this IVF at home, which got launched during COVID times, and also we started our contactless patient engagement program during COVID times. Well, at end of my session, I would like to focus your attention on Academic and Training Institute. We run a training institute called OSHRM. I'm sure people who are interested to know more about this, we have some of the brochures which are kept out, you can kindly reach us, reach out to us. We'll be happy to help you. We have two DNB seats every year, and then we run about 10 to 12 FRM courses, which is a 1 year long course. In fact, Dr. Himani is one of our students here, and all across our centers we run this program. We also have both short term as well as long term clinical courses, both in clinical as well as embryology side. I think with this, I would like to hand over the session to Dr. Rashmi. Thank you so much. Thank you.
Thank you, Mr. Sudhakar Jadhav. And good evening, one and all. I would like to invite Dr. Sushma Bakshi for the introduction.
A quick welcome to all of you. We want to catch up with the time, and I hand over after welcoming you all for our inaugural CME of Oasis to now MOC Dr. Reshmi Banerjee.
Thank you, Sushma Madam. Before we start a meeting, I would request everybody to put their mobile on silent during this session, and I'm glad to see a full house on this winter Sunday evening with so many weddings going on in the city. We would like to begin this session by acknowledging and thanking the Baroda Obstetric and Gynec Society for providing support to Oasis Fertility to bring this edition of ART Conclave.
The objective of conducting the CME is to train clinicians from across Vadodara city by the way of interactive session on the handling of ART pregnancies, latest treatments, and next-gen upcoming technologies. The stalwarts in the field of ART will help us solve the dilemma of ART. The low AMH and azoospermia confusion is going to end soon. As obstetricians, we will gain expertise in dealing with our IVF conceived patients and delivering them happiness. At the end of it, we expect the participants to get empowered with knowledge and use their clinical acumen to treat infertile couples.
So kindly sit back, relax, and we hope that the sessions will be liked by you. Now we begin our first session.
For the first session, I invite our chairpersons, Dr. Jagdish Gohil and Dr. Meenakshi Patel. Dr. Jagdish Gohil is professor in the Department of Obstetric and Gynec at Parul Institute of Medical Science and Research. He was organizing co-chairperson of Gujarat State Obstetric and Gynec Society 2019. He is very actively involved in our Gynec Society, and he is a past president of our society as well. Please, Dr. Gohil, sir, come on the dais. I invite Dr. Meenakshi Patel. She is immediate past president of Gujarat State Obstetric Gynec Society. She has been our president also. And in both her tenures, we have enjoyed a lot of academic webinars and very good conferences. And she also holds laparoscopic center for Foxy. So, Meenakshi, over to you.
Good evening to all. And first of all, congratulations to Oasis and Dr. Sushma Madam for organizing such a wonderful workshop today. It's their first workshop of Oasis. And now today's first speaker is Dr. Abhishek Shah. He is a senior embryologist and regional head of the Oasis Fertility Center. He worked in Sterling Genesis, Gopal Fertility, and various IVF centers. His work experience is quite vast in embryology with expertise in IVF and IUI lab setup. He is a life member of ISAR, ACE, and member of ASRE. Indian Fertility Society certified, and he presented many papers and has delivered lectures at various national and international conferences. So now floor is yours.
So today I'll be speaking on the cutting edge embryology at Oasis. So this entire 12 minutes of talk, I'll try to cover how with the male infertility and with the female infertility, we are trying to give the couples their biological child, and what are the advances which we are applying. So as we all know that infertility is not just a single branch. It is a combination of multiple branches like the endocrinology, gynecology, urogynec and androgynecology, radiology and pathology, and of course my work of area, that is andrology, embryology, and the genetics. So patients comes to us with a semen report. So that's always we have been taught and we are working on this, like semen is not just a count and mortality. It has a multiple diagnostic and the treatment plan values. So we not just checking the pH, pulses, color order, and the morphology, acrosome intactness, and the vitality. We try to assess the entire male fertility potential, whether the sperms are good enough to give a good blastulation and good clinical pregnancy rate. And on the top of that, if we found some issues with the male, we always try to get the DNA fragmentation index. By this DNA fragmentation index in the sperms, we try to get the genetic potential or the fertility potential of the sperms. And if it is higher, then we have multiple treatment options available, which can help us with a high DNA fragmentation index patients. So that's the AndroLife we work on. We give the multiple treatment options with the high DNA fragmentation or the any abnormal semen or sperm parameters. So that is the first method, microfluidics, which is very advanced and we are using at Oasis Fertility. So with a high DNA fragmentation, there are very low chances of getting good blastocysts to transfer in IVF, or if at all we get the blastocysts, there are chances of the miscarriages and very lower clinical pregnancy rate. So by using such modalities for the sperm, selecting the sperm for the ICSI or IVF, we try to enhance the, not just enhance the blastulation rate, but also to improve the clinical pregnancy rate. I'll show you a small video. It's not working. So with this microfluidic chips, once we install the installation the sperm, it will go through the multiple small channels. There is a membrane and the spores through which the sperms are getting filtered. Sorry, I think video is not working properly. But through the chips, we can say that once we introduce the sperm, it will go to the multiple small channels and filter through the multiple membranes and the pores to get a final volume which is having very low DNA fragmentation sperms, very good morphology, and the vitality. There's one more another modality. MAX, magnetics activated sperm shorting. So there is another modality through which we can select a low morphology, good morphology and low DNA fragmentation sperms. So as we all know that all the spermatozoa have a very limited vitality and they cease to exist through the process of called apoptosis. In this case, the oocyte fertilized by the apoptotic sperm, they are having the very low grade or low potential of getting implantation, and such pregnancies usually ends with early miscarriages. So what happens with the sperm with a high DNA fragmentation? If you can see on that left side, there is an acrosome membrane damage. So there are multiple membrane damage. So how this MAX works? So we introduce these sperms with the annexin beads. So annexin beads will stick to that sperm breech sperms, and when it passes through the magnetic column, which you are seeing on the left side, so when it is passing through the magnetic column, the annexin beads means with sperms which are having breech membranes, they will stick to that magnets and the good motile, good morphologically normal sperms, no breach of the plasma membrane, will pass through the system, and those sperms we are using for the IUI or IVF to get a good outcome in terms of the blastulation and the clinical pregnancy rate. It can be used in infertile patient who has a very high DNA fragmentation in their spermatozoa, patients who have repeated miscarriages with unidentified cause, and patients who has at least one previous treatment cycles who have poor embryo quality, which is not attributed to the oocytes. Another issues with a kind of a very low count and motility, cryptozoospermia, or the sperms retrieved from the obstructive azoospermia, or you can say very few sperm retrieved through the TISA or the micro-TISA. So the traditional freezing method is not working here. If we are freezing them with the traditional methods, there are very low chances of a good survival and getting a good sperm while it is actually needs to be used for the ICSI. So there are multiple methods available: human egg, zona pellucida, cell sleeper, petri dish, cryotop. Even we can freeze with the cryo tubes. But the novel system, which is a newly coming up, which has very good survival, you are having at least 90% good survival. I can say even you can freeze 10 to 15 sperm at a stretch, and when you throw the sample, you are getting a good sperms. That's the sperm VD that we are using now. So we have very well validated protocols for the sperm VD. These are specifically used, as I told, the crypto and the TISA samples. And the advantage of the system is optimal cell recovery, no loss of cells after sowing, motility and viability of the thawed cells are unaffected, and optimal cryopreservation after TISA or micro TISA, and it will avoid unnecessary surgical or repeated surgical retrieval of the sperms. There are other adjuvants which we are using to enhance the fertility, because what happens is sperm survival is not good. Sometimes we collect the sperm, see under the microscope good survival. When we wanted to use for IU or IVF, there is no survival or very poor survival in such cases, or even in the TISA or micro TISA frozen thawed sample. So there is no motility or very poor motility, so it is very difficult to select the sperm. So such kind of adjuvants like the pentoxifylline or the theophylline, they will enhance the sperm motility. So by introducing those supplements to the sperm samples, we are trying to get a good sperm survival and use for the IVF or ICSI. Another one is collagenase, which is enzyme. So specifically for the TISA samples, when you are teasing, I know it's more of a clinicians here, so very less of andrologists or embryology, but it is very useful in case of the TISA samples or micro TISA sample to get a good sperm quality for your IRT treatment. Also, we are using that laser for the sperms also. When we don't want to introduce any chemicals or any substances with that sperm sample, this LAH is very useful. You just tap the laser bits on the sperm tail, and you can know that the sperm quality is good or not, and you can use it for that. Not for just the sperms, for the embryos, hyaluron is another name is embryo glue, which we are using to improve the implantation rate. Cell-to-cell adhesion and cell metric adhesion have been shown been increased by the hyaluron. CD44 signaling, it increases. So when you transfer the embryos with embryo glue, there are very good chances of getting implantation after the transfer. So in short, I would like to say that using all these adjuvants, using microfluidics, MEX, or laser-assisted hatching, which is our specialty, not only the male fertility or female fertility, entire fertility, just to not, we don't want to say that count is not good, so you have to go for donors. The ultimate aim, what Mr. Sudhakar said, just to give the couple their biological child in the most scientific and ethical way. So for that, we have embryology side in the clinic, have well-established SOPs just to improve the quality, constantly looking at the checkpoints, just to improve the performance, just to improve the outcome and patient satisfaction. And all the SOPs are multiple time validated. If at all any problem with that, we always redo it, audit it, and validate it. And just make sure that quality has never been compromised with Oasis. So that's our team, the passion of the team, and there's always support of that HR team, technical team, scientific team for better outcome and services. Thank you very much.
Thank you, Dr. Abhishek. You have mentioned and you have proved that embryologist he should be good. Only the gynecologist is not the person to get the success for the IVF, because he embryologist is identifying the good sperms. They are knowing that high DNA fragmentation test and everything. Along with that, novel laser assisted hatching and all these things is done by embryologists. So good embryologist will give the best results, and best gynecologist, both the combination is required for the success of the IVF. Thank you.
It's always a teamwork. Now we switch over to the next topic. Dr. Himani Patel. She is a MBBS and MS from the MS University, worked as a consultant at Gopal Fertility and Reproductive Health Clinic, fellow of reproductive medicine, and currently she is working fertility consultant in Oasis Fertility Center. She'll be going to talk on a clinical study of neonatal outcome of IVF pregnancy. Post-ART pregnancy is having a high antenatal, internatal, postnatal, and neonatal complication. So she's going to highlight all these things. Thank you.
Thank you, sir. Good evening, everyone. So today's my topic is on the study that we have done on neonatal outcome of children conceived from IVF ICSI. It's a retrospective study as we have compared it with the children who are naturally conceived. So Louis Joy Brown, world's first IVF baby, conceived via in vitro fertilization, was born in 1978. Since then, more than 6 million children have been born using ART. According to the International Glossary, ART refers to all the interventions that include the in vitro handling of both human oocytes and sperm or of embryos for the purpose of reproduction. Usually, infertile couples, they are frequently of advanced age at the time of conception and can have a variety of underlying causes of infertility, including moderate to severe male factors. Furthermore, during the process of IVF, the embryo is exposed to mechanical and thermal chemical alterations, like supraphysiological estradiol levels. During the fresh cycles, they can alter the endometrial factors and may cause alterations in fetal growth. The process of cryopreservation can increase epigenetic modifications. It is although not yet clear whether these modifications affect fetal growth or not. Different types of culture media are used along with the extended culture media to day 5 and beyond, that is now up till day 6. These all have been associated with increased fetal weight in some, but not all studies. That's why we have conducted this study, and still it is unclear whether these factors can increase chromosomal abnormalities, risk of congenital malformations, and so on. In addition, many studies have concluded that IVF pregnancies carry an increased risk for multiplicity, perinatal mortality, preterm birth, and low birth weight in comparison with spontaneous pregnancy. However, to date, published reports discussing such aspects are sparse and controversial. It is therefore very important to evaluate whether children born as a result of ART have similar neonatal period when compared to those who are delivered from natural pregnancies. So the primary aim of this study is to compare the neonatal outcome of children born from IVF ICSI and natural conception. And our secondary outcome includes antenatal period and the complications during that period between the two groups, that is ART conception and the natural conception. So all the patients who had conceived from IVF ICSI at our center from 2030 to 2020, they were contacted and a patient input form was sent to them for filling regarding the antenatal period, delivery details, and complications, if any, and growth of the children. Similarly, data was also collected from women having babies from natural conception in the same time frame. All these data were collected and a case control analysis was done. So the group 1 is the patient who underwent IVF ICSI treatment at Oasis Fertility and conceived, and group 2 includes women who conceived naturally. So the inclusion criteria included patients having a live child, age more than 6 months, mother has received at least basic antenatal care. Exclusion, the PGT embryo pregnancy, chemical pregnancy, abortion, and child did not survive neonatal period. Coming to our results. Now, if we see the age at conception, the graph shows that for less than 25 years, there are significantly higher chances of conceiving naturally and significantly lesser number of women would require to go for IVF-ICSI treatment. While as the age increases, the chances of a female, that is the couple, requiring to go for IVF-ICSI for conception would increase. And 35 years and above, this number is significantly higher. Coming to complications during antenatal period, there are some studies who have shown that the chances of hypertension, disproportionalities, placental abnormalities, they are all higher in IVF pregnancies. But there are multiple studies and no conclusion is found till now. Our study shows that the chances of bleeding per vaginum in the first trimester, they are significantly higher in the IVF conception as compared to natural conception. And also the chances of gestational diabetes mellitus, they are significantly higher in the IVF conception as compared to natural conception. While the other complications like hypertensive disorders, thyroid dysfunction, disproportionalities, placental disorders, and chances of having intrauterine growth restrictions, there was no significant difference between the two groups. Coming to gestational age at delivery, we did not find any difference between the two groups regards to whether it is extreme preterm, that is less than 28 weeks, very preterm, or moderate preterm. So there are multiple studies which say that in fresh transfers, the chances of having preterm deliveries, there are more. But our study does not show such. This can be possible because in now IVF pregnancies, they are robustly monitored and all the possible care are given to them. So the scenario has changed. Coming to birth weight criteria, we found that the babies having 1500 to 2500 grams, they were significantly higher in the IVF conception, which falls in the low birth weight group. But in this, the IVF conception also has multiple pregnancy. So when we removed multiple pregnancy from both the twin gestations from both these groups, we did not find any significant difference in this age group. While more than 3 kg, there are significantly higher number of babies having more than 3 kg in the IVF-ICSI conception group in comparison to the natural conception group, while there was no significant difference in the average weight between the two groups. Also, we did not find any difference between the two groups in the children requiring an ICU admission. So coming to discussion, in ART, there are various protocols like fresh transfer, frozen transfer, stimulated frozen transfer, multiple hormonal supplements are used, various interventions like LH, adjuvants are used like embryo glue, there are long extended in vitro cultures, advanced sperm processing techniques are used. These have been rapidly adopted into the ART practices, and these require constant evaluation of safety concerns, that is regarding the epigenetic and perinatal outcome of the children born from these procedures. So that's why the rigorous monitoring of IVF-ICSI children, it is very important. In our study, what significance we found, that is higher age in IVF-ICSI, that is as the age of the female increases, the chances of the female requiring some form of assisted reproduction technology increases. Incidence of bleeding in first trimester is higher in IVF conception. Incidence of having gestational diabetes mellitus is higher in the IVF conception, as well as female having large for dead babies, that is more than 3 kg, is higher in the IVF conception. While in rest of the things like female developing gestational hypertension, placental abnormalities, abnormalities, preterm births, percentage of children having low birth weight and requiring NICU admission, we did not find any significant difference. Limitation, it's a retrospective study, that is recall bias, and also there is heterogeneity in the socioeconomic condition of patients in both the groups. This study provides data on the effect of ART in Indian population, which are very few till now. Our study includes both ART and naturally conceived children, which provides a better understanding of the implications of various procedures done in IVF and ICSI. So to conclude, there is no difference in the incidence of preterm birth, low birth weight, and NICU admission in the naturally conceived and IVF-ICSI groups, while the percentage of female diagnosed with gestational diabetes mellitus and having bleeding episodes in first trimester are more in IVF-ICSI group. This is one part of this study, but what's more required is how these children fare in their further growth, whether they are achieving their milestones in comparison to the natural conceived baby. similarly or not. So that study also we have started and we'll publish it very soon. Thank you.
Thank you very much. Your lecture shows that there is no difference in IVF and natural conception, but in a practice we see something different. The third stage complication, PPH, and placental abnormalities are also been found more with IVF pregnancy. Anyway, thank you very much.
Questions will be taken at the end. I request the chairpersons to please give the mementos to the speakers.
Hetal, please get the mementos for both the speakers.
After this, I request Dr. Shujat Wali, please, to hand over the memento to Dr. Jagdish Patel. And Dr. Mayur Bhagat. Sorry, Dr. Mayur Bhagat, please give the memento to Dr. Meenakshi.
Now I take the opportunity to introduce a second session. The chairpersons for the second session are Dr. Deepa Patel, who is at present the Secretary of Baroda Obstetric and Gynec Society and also Associate Professor with the Gotri Medical College, and also an IVF consultant at her clinic. And the second chairperson is Dr. Varuna Bhaya, who is a consultant at Oasis Fertility and has her own fertility clinic, Karishma Clinic, and has an experience of 47 years of experience of practicing in Baroda, in the city of Baroda. And teacher par excellence, I mean, she was a person along with her and Bakshi Madam, I learned on my ovum pickup and transfer. So, I mean, madam से कि डरती क्यों है, लगा जोर लगा और पंक्चर कर दे. That was how my first pickup was there with Varuna Bhaya madam. Please, okay, you can introduce the speakers now.
Yeah, we have a first speaker for today, Dr. Vaibhav Kapadia. He needs no introduction, actually. We have heard him a lot of times. And his areas of interest are endoscopy and ART. Major achievements are a lot of awards, papers at alpha-dopine unit on alpha-dopine neonatal jaundice, blood products, and hysterectomy. And he's the consultant obstetrician and gynecologist at the Ramaben Hospital, Navsari, director of Narmaha Healthcare, Mumbai. May we have Dr. Vaibhav Kapadia, please?
Thank you, Madam, for the fantastic introduction. Am I audible? Yeah. First of all, before I begin, I'd like to thank Dr. Bakshi ma'am, Baroda Society, and Oasis Fertility for inviting me here today to speak on ovulation induction in IUI. IUI represents one of the first line treatments in ART. It's because it's safe, less invasive, and relatively cost effective. But when you combine IUI with ovulation induction, it significantly improves the IUI outcomes. It even doubles pregnancy rates in unexplained subfertile couples. But we need to figure out why or what causes their anovulation. And our treatment usually depends on that, whether it's hypogonadotropic hypogonadism, PCOS, primary ovarian insufficiency, or hyperprolactinemic anovulation. But what's our goal? Our goal of ovulation induction along with IUI is to induce monofollicular rather than multifollicular ovulation, monoovulation, a singleton pregnancy, birth of a healthy newborn, and we want to focus on a cumulative outcome rather than a per cycle outcome. That is what we want to achieve. So we start with the least invasive, simplest, and cheapest treatment option to begin with. And then you subsequently alter according to the results that you get. What we want to make sure is that you minimize OHSS and minimize multiple gestations, and don't be afraid of canceling the cycle when it goes out of hand. So what are the prerequisites for IUI and ovulation induction for that? Is to ensure that you have at least one patent tube, you have enough number of sperms to inseminate, and you have documented that there's no acute pelvic infection. But a lot of times when patients do reach to us, they are slightly older, and as of now, we have the means to check their ovarian reserves. But when do we want to check these ovarian reserves? Especially when women who are more than 35 years of old, there's unexplained infertility. There's the previous cycle where someone has tried ovulation induction and has not got any results. There's history of ovarian surgery, or the maternal relations have a history of early menopause. In these patients, even if they come to you for another, say, concern, please advise them to go in for an early fertility treatment. But one thing we need to ensure to tell them is that decreased ovarian reserve does not mean inability to conceive. So how do we check this ovarian reserve? There are clinical markers like age, a regular menstrual cycle. You could check endocrine markers like FSH, LH, E2, AMH, which is readily available. I'm sure someone is talking a lot on that after me. Ultrasound markers like ovarian volume, antral follicle count, and ovarian blood flow. What we've also imported from the IVF is to measure which patients will have a poor response. And in a lot of IVF cycles, we use something called as the Bologna criteria, where 2 out of 3 indicate a poor ovarian reserve, like age more than 40 years of age, less than 3 oocytes in previous stimulation, and abnormal ovarian reserve tests like AMH and AFC. We could actually use this even before stimulating a patient for IUI, understand that they might have a poor outcome, and explain them accordingly. So what are the treatments? What is the way that we can start ovulation induction for IUI? And the first thing that comes to all our minds is clomiphene. That's what we've been taught, that's what we've been known. But now it's time to put that a little back and start with letrozole. Letrozole has now become the drug of choice in ovulation induction with PCOS. It is an aromatase inhibitor. You start with 2.5 milligrams per day from day 3 to day 7. Usually people use up to 5 milligrams a day. Even some people have used up to 7.5 milligrams a day. But the reason we started using this over clomiphene is because of the endometrial thinning, which we found with clomiphene. What one must remember is with higher doses of letrozole, you will find the same endometrial thinning more than 7.5. Newer regimens are always being tried out like a single dose 20 milligrams, but we still need to check. Like every new drug, like every new procedure, when it first comes out, you want to start using it for everyone, and it's fantastic, it's amazing. Then we found out with letrozole, oh, there is some teratogenicity that's happening, and it got banned. So we went from it's fantastic, let's use it for everyone, that it's so bad I won't even give it to my dog, to now lots of studies have come out showing that it's safe for use and it's found its own place in the system. So letrozole provides higher birth rates than clomiphene, similar rates of malformations, and it's now the first line therapy in oligoovulatory women. It has a significant increase in live birth rates in overweight women. But that we shouldn't forget clomiphene. Of course, it has been most widely used since the last 50 years. It's been used in dosages of 50 all the way up to 250 milligrams per day. But we've seen that more than 150 milligrams per day, it has no benefit. The advantage of clomiphene over letrozole is that suppose a patient comes to you slightly later in the cycle, say up to day 5, you can still start with clomiphene. However, you'd want to avoid that in case of letrozole because of its anabolic effects, and that may cause a derate or some amount of teratogenicity. The problem with clomiphene is there's resistance up to 40%, even though there's ovulation seen up to 80% because of its hyperestrogenic action. The maximum pregnancy rate that you achieve with IUI and clomiphene is 8.5 to 10%. Which brings us to the use of gonadotropins. Lots of gonadotropins available in the market, HMG, urinary products, FSH, recombinant products. People use all of them depending on what place they are in, what economic budget that the patients have. But all in all, the difference is not statistically significant. When you stimulate a patient with gonadotropin, the pregnancy rates achieved are close to 15 to 17% per cycle. But this comes with an increased cost of treatment, increased risk of OHSS, and increased multiple pregnancies. So what are the regimens that you can use? The standard regimen initially described was start with 150 international units from day 3, go all the way up to trigger. But this led to a lot of costs, a lot of multiple pregnancies, and a lot of OHSS. So no one really uses that anymore. What people generally tend to use is the step down protocol, which is more natural. We start with 150 international units a day, monitor them until the dominant follicle achieves 10 millimeters, and then you reduce it by 37.5 every 3 days until you use 75 international units until the trigger. But with PCOS, you would want to go slow. You want to start with a step-up protocol, where you'd start with a low dose, 37.5, or even maybe if you want to risk it, maybe 75 international units. Wait for a week. Continue with the same dose until you move on to a slightly higher dose and you achieve the desired number of follicles. But is gonadotropin cycles worth the cost? That's the point. With IVF available today, is gonadotropin only cycles available worth it? There is risk of multiple gestations. OHSs make it very less cost effective. So the trials were conducted where normally when a patient would come to you, say all the way to her pregnancy, you'd give her maybe 3 cycles of clomiphene or letrozole, give her 3 cycles of a gonadotropin IUI cycle, and then move on to IVF. So they tried and studied how much it costs. And then they removed the gonadotropin IUI element from there, treated them with letrozole and IUI, and straight shifted on to IVF. Showed that with the accelerated protocol, that resulted in a shorter time in pregnancy and actually saving some money. But like all of us, who doesn't like a good jugaad? We always want something that's good, that has good, it's gives you a speed, it's highly efficient and reducing costs. So people thought, why not add letrozole to gonadotropins? A lot of us have this mindset of adding gonadotropins to letrozole, but no, actually if you add letrozole to gonadotropins, what if you could reduce the cost? What if you could get a good clinical pregnancy rate? It's actually possible. Letrozole has no anti-estrogenic effect and has a short half-life, as we mentioned, and it has no unfavorable effect on mucus, or cervical mucus and endometrium. So you could use it by using letrozole from day 3 to day 7, followed by a urinary or a recombinant product, gonadotropin, until you hit the trigger. There are some studies which have even used it concomitantly, like using letrozole and gonadotropins together on alternate days. What does the evidence suggest? Using this protocol, you can actually significantly reduce the cost, actually significantly reduce the dose of the gonadotropins, actually significantly reduce the days of stimulation, and actually increase the clinical pregnancy rate. Although clinical pregnancy rate is not statistically significant, but it is still higher than gonadotropin. There was no difference in the neonatal outcome, no difference in gestational week of delivery, no birth weight differences, no APGAR score differences. So why not use it with clomiphene in places where letrozole is not available? It will reduce the cost. It will reduce gonadotropin, but because of the anti-estrogenic effect of clomiphene, it will lower the pregnancy rate. Another thing we've borrowed from IVF is the use of antagonists in our IUI cycles. It does prevent premature LH surge, prevents premature luteinization. It buys you time to correct the ovarian endometrial asynchrony, and it can be added to the ovarian cycle once the follicle is more than 14 millimeters. But majority of us use it also to avoid the Saturday, Sunday IUIs, so you can plan it accordingly when your lab is open. It will increase pregnancy rate, but it does not guarantee you live birth rates. Ovulation induction, we need to monitor them using ultrasound. Follicular growth is monitored, endometrial thickness is monitored, Doppler studies are done, E2 studies are done. Even LH kits are given to the patient in case they cannot keep coming back and forth to the clinic for an ultrasound. So how do you want to optimally simulate these people? You want to up to maximum of 3 follicles, wherein E2 is 150-250 milligrams per follicle, endometrium is more than 8 millimeters, and please don't hesitate to cancel the cycles when you have at least more than these follicles or the estrogen is very high. You could use the trigger at more than 18 millimeters a follicle. Use the trigger only more than 26 once you're using clomiphene. Endometrium is more than 7, and you could use GnRH analogs, or you could use HCG more than 10,000, or a recombinant HCG to trigger. GnRH analogs, when people started using it for trigger in IVF, and it went into disrepute because the clinical pregnancy rates went down. Later we realized that this was causing luteolysis, and that caused a big luteal phase defect, and this led to a decrease in clinical pregnancy rate. So people were a little scared of using this even for IUIs. But now, with newer studies, it's shown that the luteolysis occurs only with multifollicular patients. This has a hyperestrogenic environment, and that causes luteolysis. So by some chance, if you did have or could produce a monofollicular growth and a monofollicular ovulation, the luteolysis will not occur. The GnRH analog trigger will mimic a more natural way of triggering and actually give you a higher clinical pregnancy rate. So once you've triggered the patient, you need to time the IUI. You could do a single IUI or a double IUI, depending on what your center believes in. Pregnancy rates are similar. Double IUI is only superior in cases of male subfertility. Recent reports suggest that you change the way you do IUI, the timings according to the product you use to trigger. If you use urinary HCG, you do 24 hours later. If you do triggered with recombinant HCG or an analog, you can go up to 42 hours. Luteal phase support in these induced cycles for IUI is extremely important because it increases the pregnancy rates substantially. You can use the progesterone vaginal suppositories. You could use dydrogesterone. You could use oral pills, natural micronized progesterones. If you used an analog for a trigger, I suggest you supplement the estrogen as well, and this will lead to increased live birth rates. The adjuvants used for these ovulation induction is metformin and cabergoline routinely in patients who need them, like hyperinsulinism or hyperprolactinic patients. But a lot of times we see that they've been used empirically, and that actually does not have any effect on clinical pregnancy or live birth rates. What's known to help in cases of IUI is that if you have a thin endometrium or all the time that you have recurring thin endometrium, is that you use PRP or GCSF, that increases the endometrial thickness, but whether or not it actually affects the live birth rates is yet to be seen. A lot of patients will walk into our clinics saying that we need an IUI, even if they've got multiple IUIs. That is sometimes we need to say no and say that enough is enough. And those are the times, like there are multiple IUI failures. There's very poor sperm morphology, and an extremely low AMH or probably almost a nil AFC. I thank you very much for a very patient hearing.
Thank you, Dr. Vaibhav. It was an excellent deliberation in the short time which you were given for this topic. And we all definitely agree that though IUI is a time-tested method and the methodology for performing has not changed, but the evolving IUI stimulation protocols have definitely helped us to achieve a better results with IUI. And that was very well covered in your talk. Thank you very much.
Thank you so much.
The second speaker is Dr. Krishnan Chaitanya. He's from Oasis Fertility. He's the scientific and the clinical head, handles the things. He has been working since last 15 years. He's an expert in clinical embryology, cryopreservation, and genetic. Has extensive knowledge of latest ART procedures. He constantly researches in innovations, approaches to the improper success rate of IVF treatment in PCO and recurrent IVF failure cases. Main areas of work are cryobiology, in vitro for maturation of the oocytes, embryonic stem cells, andrology, and men's health. He will enlighten us with azoospermia. Is it an end or the new beginning? Dr. Krishna.
Good evening, everyone, and thank you, madam, for that kind introduction. So, just not azoospermia, just put a bit more focus on the emerging trends that have come with management of male factor infertility. I think there's so much that we do with the female side. I think right from giving clomiphene to doing a lot of interventions where we're now talking about stem cells for women. I think when it comes to the male factor, I think we just limit it to a semen analysis. If it's not good, we just say refer to urologists. And if urologists do not find a role for surgical management, all that they want to do is just say ICSI. So is ICSI the only way we're going to manage the male factor infertility? Literature says the answer is no. I think there's so much more that's coming up. And the literature says that we've got to be involving the man right from the beginning. So let's quickly focus on certain aspects which have changed in the recent times. And we'll give more focus on azoospermia, which I think for patient also it's quite a difficult situation, and more so for clinicians also. The moment we see an azoospermia report, I think there are a lot of question marks going on as to how do we really tell to the patient. So let's quickly give some focus on that. We all know the fact that there's equal contribution of the male factor now in a couple's infertility. It's just not a woman's problem anymore. I think what we really are moving away in the year 2021, I think we're moving away from this concept of donor. There was a point where if we didn't have an option, we said third-party reproduction was the only way, or adoption was the way of going ahead. But now I think we want to offer self-gamete conception to the couples who come to us. You know, self-gamete conception is the motive in the 21st century now. And what is changing all of this? Specific to male factor infertility, the first thing that changed the way we practice male infertility is invention of ICSI. Way back in the year 1992, we all know it was an accidental invention of this procedure, ICSI, which really gave an uplift the way we can manage male factor infertility. Otherwise, donor was the only way we could have handled male factor infertility. I think our understanding of surgical techniques and how to handle these sperms retrieved from testis and epididymis has really gone a long way in the last 3 decades. And that's another way, another reason why we're having better success rate in the present scenario. Cryopreservation. I think if this was not invented, we wouldn't have had a successful practice, right from going to a concept of no OHSS clinic to having the best success rate. I think cryopreservation has been a very significant way of improving success, and more so with male factor infertility, where you can now freeze the testicular sperm and even the testicular tissue as a part of oncofertility. And our culture systems, our understanding of what the egg, sperm, and embryo needs in the laboratory to give the best outcome has gone a long, long way. Way back in 1978, what we understood about the embryonic needs or the gamete needs is way too different. And I think we are able to generate better quality embryos, which is helping us with good implantation rates. A lot of deeper insight into the molecular medicine and genetics. I think this is helping us prognosticate the outcomes and also, again, give and offer a lot of successful treatments. So with that background, where things have changed, how are we approaching an infertile male? And in 2021, how are we going to really deal with this entire thing? Let's not forget a basic thing taught in the second year of our MBBS, history taking and physical examination. In the era where so much of imaging and testing is available, are we really not wanting to touch our patients? I'm not being gender biased, but a gynae department where there's so much of women primarily working. I'm not get biased, Dr. Vaibhav there. But I think we do not want to examine the male. We just want to get an ultrasound scan done to understand the testicular volume or the other aspects of the male reproductive tract. But I think without taking a proper history and examination, I don't think management should start. And that's what the flowchart here says, that there are certain very, very spotter kind of things that you could pick in the history and say, no, probably I'm going to deal with something that's going to be detrimental to the reproductive outcomes, and those cannot be missed. More so the lifestyle factors. I think at least the modifiable lifestyle factors, chronic smoking, binge alcohol, and obesity, which have become a common thing, whether it's a city or a village or a district place. I think we are coming across these lifestyle issues which are affecting the reproductive outcomes. Examination, apart from the virilization and the Tanner staging, the local examination, testicular volume, the mere presence or absence of the vas difference is going to give you a clinical diagnosis, which is going to help you manage the patient better, and then comes the investigations. There are hardly not many investigations that we're going to do with the male. Apart from your semen analysis, I think we have the reproductive hormones, and probably in imaging, it's just a transrectal ultrasound, Doppler, and genetics, and that ends the investigation part of male factor infertility. So how do you schematically approach an azoospermic men who come to you? I think that's a quick glimpse. I'll not take into greater detail, but after you've taken history and examination, a second semen analysis, at least 6 weeks to 12 weeks apart, is something that is recommended, which is properly done. What do I mean properly done? The lab should be centrifuging it and thoroughly examining it, and then only a final diagnosis from a lab side of azoospermia should be done. Rule out retrograde ejaculation by doing a simple test of post-ejaculate urine, and then the examination. That will give you whether you're dealing with a non-obstructive azoospermia or obstructive azoospermia. If it's obstructive azoospermia, in the current scenario where the surgical sperm retrieval techniques have improved, I think the role for doing vasoepididymal anastomosis, or all those surgeries, those microsurgeries, are coming down because the success has never been great. But the success with testicular sperm has been wonderful. So I think just do a trial teaser. If you're getting sperms, freeze them. So these investigations are more a guidance. They're going to help you prognosticate. They're going to help you counsel the patient, because so many times it's quite devastating onto the couple, to the family, when they hear the word azoospermia. I can never forget, there's one little incident with my dear colleague It was her first day of work at one of our new branches, and the first patient she saw was azoospermia, a very well educated patient. And then she casually just opened up the file and she said, you know what, we did your semen analysis and I don't think we see any sperm in the semen that you gave. And that fellow just collapsed. First day at her work, first patient, she had to end up resuscitation the patient, and then onwards, every time it's azoospermia, she says this is such a difficult thing, and she really takes a lot of time, counsels them, and takes it the right way. So men are quite difficult to handle in fertility clinics. Women are easy. That's one side where you could flip and say women are easier to handle in the fertility industry out there. So that's so that's a schematic thing. I'll not go greater into the detail of that. But clinically, if you have an azoospermic patient, where is it that you're going to have wonderful prognosis? People with normal reproductive hormone levels, that is FSH, LH, and testosterone, a normal testicular volume and examination, a normal Y chromosome microdeletion testing. Of late, in all men who've got sperm counts less than 5 millions, it's recommended that we do a karyotyping and a Y chromosome microdeletion testing. And based on the deletion, whether it's present in the A, B, or C segment, you can actually prognosticate your sperm retrieval success rates. And of course, your histopathology report also tells you about whether you can get sperms if you're going to go and do something called as a micro dissection of the testis, which is micro TC. So few points which could tell you in your clinical workup, in history and everything, that you have a patient where you could give them some amount of hope, and that's what those little points are all. So, I always love this concept of 5, which my teacher taught me. When you have a man in front of you, look at these 5 concepts. From the history and examination, did you really find something that's positive? All right. What are the investigations? Do not unnecessarily get the investigations. What's relevant based on your semen analysis? Interpret your semen analysis properly. That half of the work is done there. Interpret it properly, and then what are the additional investigations and what information are you getting with that? Is there a role for medical management? Is there a role for surgical management? And what is the choice of ART? 5 concepts. If you can break up every man who's coming to you, I don't really think we have to send every patient to urologist. I'm not against a urology community, but urologists are surgeons. They love cutting open. They're not going to sit there and counsel the patients and waste their OPD time for the infertile patients. I think it's always good to keep the man and woman with us in front of us, because we know half the story. What's happening with the female there with her ovaries, eggs, and what is she likely to end up with? Sending them to urologists where they're not really going to connect the story well. We can knit the story well. And infertility is a couple's problem, and let's treat the couple and just not two individuals separately. So is there a role for medical management in azoospermic men? Only if you see there's hypogonadism. If your testosterone levels are less than 300 nanogram per deciliter, that is when there is a role for medical management. Otherwise, the answer is absolutely no. Use of clomiphene or letrozole or HCG, none of those help if your hormones are normal. Empirically putting them on some kind of medical management for 3 or 6 months, you're just wasting the couple's chance of conception. Sooner you do the trial biopsy or the testicular biopsy TISA, you have sperm, go for ICSI, close the chapter. There is no beating around the bush with the azoospermic men if you've really had everything normal and it's unexplained. But if there's hypogonadism, correct it first. How do you correct it? Absolutely no for testosterone of any form. A man who's not completed his reproductive needs will not get shot with testosterone. Your choice is HCG here. So HCG either in 5,000 units or 2,000 units is what you can try and give. And nowadays we're talking about giving FSH. Again, if you're giving FSH, make sure your FSH, what you've tested in the serum, is less than 8 international units. Anything beyond 8, again, there's no benefit in giving FSH, but role of FSH is still controversial, and that's a wonderful paper, free for download, 2021. It's a review article which has tried and compared the use of various medicines that we could use in non-obstructive azoospermic men, and the conclusion is there isn't much benefit or help that we're going to do by giving medical management in these men with non-obstructive azoospermia. But if you have to, then probably it is HCG or FSH, but depends on your reproductive hormone. So please take that with a pinch of salt. We just can't go and randomly shoot every man with HCG and FSH injections. Surgical management. Before even you think of retrieving sperms from the testis, if there is a clinically palpable varicocele, trust me, the ultrasound is not going to make any difference. It's your clinical palpation, clinical examination, your experience. You can pick up varicoceles wonderfully and beautifully. And you go to ultrasound and you get it done. I think they've got different classifications. There are at least 4 or 5 different ways, and a grade 2 is what I believe as an andrologist could be very different to what the radiologist would believe in. So that's really putting us at a lot of conflict. But every varicocele that's more than grade 2 needs to be managed. And there are reports, a wonderful review written by Sandro Esteves, a very famous andrologist from Brazil. And he's shown that through his meta-analysis that if there's varicocele, if you're correcting it, the chances of having sperm in the ejaculate is going up by almost 39%. If that's not happening, at least your success of retrieving sperm from the testis is better. So if there is a clinically palpable varicocele, it needs to be first managed, then wait for 3 months, and then you go ahead with whatever is required for the patient. So that was the systemic review and meta-analysis. Another one in Asian, this where they're looked at multiple publications on this particular aspect. And they really looked at different kinds of histopathology, Sertoli cell-only syndrome or maturation arrest or hyperspermatogenesis. You've done a trial teaser without correcting varicocele, and then you have a diagnosis histopathologically, and then you do a varicocelectomy, and then you again redo your surgical retrieval. And they've seen that the retrievals have been better in these 3 situations. So having a histopathology report sometimes is very important, because that's going to help you in prognosticating the outcome of these patients. I'll not get into details of the surgical retrieval. I'm not a surgeon, but I think gone are those days where you're going to do a TC. Open biopsies are a no-no in 2021. You want to do a trial teaser, you just have to, it's simple, give a local cord block, take a 20 cc syringe and a 18 gauge butterfly needle. You just have to do a fine needle aspiration. The seminiferous tubules are going to come out beautifully. It's just a little technique. Please go learn it with a urologist. It's very simple. It saves a lot of cost and effort to the patient. You have sperms, freeze them. So I think teaser is the way we're going to do this. Opening a testis is a no-no in the current situation. But the reports say that if you have to do a micro TC, where you're going to use a bipolar cautery where the blood loss is minimal, the fibrosis post-surgery is minimal, hypogonadism post-surgery is going to be minimal, and your retrieval rates are better with micro TC. And that's what we have been started to do for certain indicated patients. We directly take them through micro TC, very low volume testis, where we know that the retrieval of sperms is going to be less. We counsel them and we directly do a micro TC so that the damage and the extent of hypogonadism post-surgery is going to be less. But I think micro TC is now the way of handling these non-obstructive azoospermia where the prognosis is guarded. Another interesting thing, this paper was published in ASRM in Fertility Sterility year 2020, where we compared the outcomes of fresh and frozen teaser. Why do I want to talk about this? Is we send our azoospermic men to urologists. They do a trial biopsy. They send it for histopathology. It says spermatogenesis seen, and then you're sending back the patient to a fertility center where the biopsy needs to be repeated. In the current scenario, you do not have to do any of that. At trial biopsy, make sure an embryology team is available to pick the sample up. They take it to their embryology lab. They tease it. If there's sperm, they freeze it. The outcomes, whether it's fresh or frozen testicular tissue, provided the embryology team is well versed with the technique of cryopreservation, the outcomes are no different. Our live birth rate between the fresh and frozen was absolutely not different. And at Oasis, all our trial biopsies are frozen, and all our XCs are with frozen teaser samples, and we've had a wonderful outcome. So take-home message, in the present scenario, doing a trial teaser without a frozen backup is not accepted. We shouldn't be putting the patient in an unnecessary thing. So the technology is improving with the azoospermic men, especially the Klein filters, or where we know that the sperm is going to really go bad as the age is advancing. Even in the Y chromosome deletion, if it's in the C region and you've picked it up pretty early, or a bad varicocele which is picked up in a teenager of a child, then you can do a sperm retrieval pretty early. You could use this newer technique called as sperm vitrification. Even if you've got 10 or 15 sperms, they are well retained and protected, and the outcomes have been fantastic, and we've been using this for quite some time. Israeli method, which we've been very instrumental in getting it to the Indian community. We wrote to them. We did a lot of follow up with these Israel groups saying that we're interested in doing this, and finally it's now freely available in the Indian market, not very expensive. So that was quickly to show you all that the outcomes, the reproductive outcomes with testicular sperm or the other one is not going to make a huge difference. We always have carried this concept that severe male factor infertility, the reproductive outcomes are not going to be great. It's better we use donor sperm. 2021, this concept doesn't apply good anymore. Whether it's testicular sperm or ejaculated sperm, it's not making a difference, because ICSIs, the whole culture thing, what I spoke in the beginning, is helping us. And that's the Chinese data, which is published in Nature. A large number of studies used in that. They quote a live birth rate of 45%. So this is Oasis data, which again was published in the year 2020 in Fertility Sterility, where we did show that Indian data of live birth rate of 40% with testicular sperm, which was both fresh and frozen testicular sperm. So I think the data is there. It's all well published, whether it's ejaculated or severe male factor or testicular tissue. It's not making a difference. Donor is not your first choice of treatment. So nowadays we're doing TISA for other indications. Traditionally we've only used it. Last 3 slides. I'll just take 2 more minutes. We know that only non-obstructive azoospermia we do a TISA, but now I think the indications have been extended to people with severe oligoacinoteratoma, cryptozoospermia, men with raised sperm DNA fragmentation, chronic prostatic infections which are not coming down with 2 or 3 courses of antibiotics, or men with collection difficulties and ejaculation. So in all these cases, we can offer TISA, which is very simple. The concept of donor is moving away. In all these cases in the past, probably would have offered donor 20 years or 30 years ago, but now in 2021, we can do TISA and the outcomes are absolutely great. But where is it that we could still use donor? I'm not saying donor has vanished, but I think the usage has really come down. A quick glimpse and I close my talk. So I think first thing, I think donor insemination has to be anonymous. Friend, brother, the IIT student, IM student, absolute no. You cannot know the donor. The recipient and donor cannot get their identities known, and they have to be less than 35 years of age, and they need to have undergone a karyotyping and a thalassemia for sure. Every sample should be quarantined for a minimum of 6 months for the risk of HIV transmission. So all your donor samples have to be frozen. There is absolutely no concept of using fresh donor semen sample. That would give us a better pregnancy outcome. The answer is no. It has to be quarantined for 6 months, retested for HIV virus. It's all free. That is when it's all good to be used. Quarantine and tested samples. That's the right practice. Thank you so much. That was the emerging trends about the male factor infertility. Thank you so much.
Thank you, Dr. Krishnan. You have given us a good idea and the details of all the azoospermic treatment and everything. I remember when I started infertility work, that was the time when azoospermia means donor sperm. And even the routine of quarantining the sample was not there. Because I remember myself in 90s, we used to collect the sample, send somebody to the hostel and get boys, get the sample and use it as donor sperms. That has absolutely gone and it's a good thing. Thanks a lot.
We have our next speaker, Dr. Om Lakhani. He's a consultant endocrinologist at the Zydus Hospital, Ahmedabad. And it's a pleasure always to hear him. That's why I think we're having him twice in the last 14 days. And he needs no introduction. He was an alumni of the Baroda Medical College. And it's really a pleasure to have him. He's going to speak on AMH, a marker in infertility.
Vaibhav has done so well, and then aided by Dr. Krishna.
Yeah.
So expectations from you are higher. But I'm sure you're going to do it.
Yeah.
No, absolutely. You have all the rights, ma'am. Yeah. So thank you for this session, and I think it's always a pleasure to talk in a cross-speciality talk. I think it's always something. In fact, sitting there, I learned a lot in the previous talk, so I think it's very useful to my practice as well. So I think it's a very useful thing. And I think I'm a very firm believer of the fact that any innovation really comes from the bleeding edge of two specialties or multiple specialties. As you can clearly see, infertility is the bleeding edge of multiple specialties. You have so many specialties involved in the care of the patient, and then now you see a beautiful fertility outcome. So we are going to go to something very basic today. We are going to talk about AMH, that's the anti-Mullerian hormone. We'll talk everything about it, right from the physiology to the clinical laboratory medicine, as well as the clinical applications of the same. Okay, so let's talk about the physiology. So as the name suggests, it's the anti-Mullerian hormone. It's technically supposed to be useful in men, and that's where its genesis really comes from. Now, as you can see, by default, we are all destined to be women, right? But nature takes a course a little bit sideways in certain people, well, 50% ideally, and there's a production of an AMH and testosterone. And what AMH does is it suppresses the Mullerian structures. So you have the, as you can see, the pathway diverging towards the male side. And yeah, sorry. Okay, pointer is not working. Okay, we have, it going towards the male side. And if nothing really, if there's no AMH early on, then you have by default the Mullerian structures which are produced, which go towards the female. Now, that, there are two different cell lines in men. Both are extremely important for the male to really, be a male. You have the Leydig cell, which produces the testosterone, which goes on to produce the external genitalia, and the Sertoli cell, which produces the AMH, which suppresses the Mullerian structure, leading to the male internal genitalia, developing in the proper way. So this is the two things. But what's very important is, and we'll come to this again and again, AMH is the marker of the Sertoli cell function. That's a very important thing in men. And though, of course, we are going to focus on female infertility, there are a few aspects of AMH in the male infertility as well, which I'd like to really touch upon. Perhaps, topic for future research. Now, what really happens if there is no AMH in men? Well, you have a condition which is known as the persistent Mullerian duct syndrome. So if you have AMH, if you don't have AMH, and if you have testosterone, you have the male external genitalia, but the internal female genitalia, the Mullerian structures, are still persistent, right? So you see this rare condition. We do see this in clinical practice. It's a rarity. It's a unicorn, you can say. If you don't have either the testosterone or the Leydig cell or the Sertoli cell function in an 46XY, then you have a female genitalia, and that is what is known as, well, it's the complete gonadal dysgenesis, and you have the female external genitalia which happens. So this and they later on come with primary infertility and primary amenorrhea, and that's what the male version of the Turner, or 46XY version of the Turner. That is what it is. Okay, what about female? Now, what happens is female. That is what we are going to focus mainly in the rest of our talk. Now, AMH, remember, in men, it is secreted as early as about 8 to 9 weeks, because it carries out a very critical function at that point of time. But in women, AMH is secreted at about 36 weeks of life. So it is secreted at a much later time. The levels start increasing from birth up to childhood. The peak is reached at around 15 years of age. It remains stable up till 25, and then starts declining gradually over a period of time, right? As you can see from the graph over here, right? And I think this pretty well correlates also with the fertility as well, right? So, you have that young women who fit into the perfect AMH zone, where of course the fertility is also pretty good. What cells produce AMH in women? And I think this is the important chart here. Remember, AMH is produced by the granulosa cell of pre-antral and small antral follicles, and 60% of this is produced by follicles which are between 5 to 8 mm in size. That's the critical period. And more than 10 mm follicles do not produce AMH, right? So as it evolves, the production of AMH kind of starts reducing. So you have mainly the early small pre-antral follicles and antral follicles which produce the AMH. Now, the idea of AMH and what's the purpose? What's the main role of AMH? Well, AMH is the nature's, anti-OHSS thing, right? It prevents multiple follicles from developing at the same time simultaneously. So what it does is it allows the dominant follicle to evolve, but at the same time suppressing the other ones from developing, right? That's the main idea, right? So you don't want, too many of them evolving at the same time leading to OHSS. That's the idea. We sometimes, do bypass that system, what we're doing in fertility, but the idea is the nature's own way of having a singleton pregnancy. That's the ultimate outcome. It also prevents the early follicles from atresia. So it maintains a good pool for further development, right? So it's basically what it's doing is it's like the nature's babysitter, right? It's preventing the babies from, moving out of the house, keeping them in and keeping them happy, right? When the mom comes home, right, you have things are fine. Okay. Remember, by puberty, 95% of the follicles are lost in girls, right? So that's, you have a rapid atresia and you need this nature's babysitter to keep them, the remaining ones in check. Now, there's a very interesting dynamic happening between the, various other hormones of the body. So the FSH, it stimulates the AMH production. FSH also stimulates the estrogen production. But AMH and estrogen are not friends for a lot of time. So estrogen inhibits the AMH, right? So this is a cycle which goes on, right? At different parts of the, female reproductive cycle, you have different dynamics in play. But I think this picture really tells you that there is FSH both directly stimulates AMH, but at the same time indirectly inhibits its production. So there is a very interesting dynamic in play over here. And what about LH? Now, LH also does not have a direct impact on the AMH, but LH suppresses the AMH receptor. So it has an indirect action by which it kind of, bypasses. Now, technically speaking, how much of this is important at this point of time in female reproductive cycle, we don't know, right? A lot of these are coming from, from mainly rodent studies and so on. But the idea is that the more we understand this, because I think, what is going to happen now is that more products are going to develop from the field of AMH. So you'll have either AMH agonist or AMH antagonist and other things being developed in terms of fertility, because this is an area of active research for a lot of people. Now let's look at the biochemistry side of it, the AMH assay. Now, does it require a particular time of the day or does it require a particular time in the cycle? The answer is actually no. You can measure it any time of the day. Well, we prefer measuring it in the morning time, but really does not matter, right? I mean, it could be part of your, rest of the tests which you're doing as a part of your fertility panel, but you can do it separately when the patient just walks into your clinic as well. It can be measured during any part of the menstrual cycle. And these 2 points actually make it a very attractive test. In the sense, when the patient walks in, any time of the day, right? Afternoon consultation, morning consultation, doesn't matter, right? Fasting, non-fasting doesn't matter. The timing of the cycle doesn't matter. You just take the sample and run the test, right? That's the beauty of doing an AMH. And that's why I think there are practical aspects which often make this test is a very attractive test, perhaps in the future. It's mainly done, but commercial assays are mainly done by ELISA Clio. What is important is you have to understand what assay is being used by your lab. Remember, the cutoffs are still not standardized. I'll come to this point again and again, right? So always look under the hood, and look at what assay is being used by your lab. What are the cutoffs? What are the, fallacies of the assay, and so on and so forth, right? Remember, a lot of your decision making is, I understand, based on AMH as well, and that's why it's very important to understand that assay. When like, for example, for an endocrinologist, dealing with diabetes, HbA1c is extremely critical, right? And all my decisions are based on HbA1c. I need to know how my test is done, right? Without that, really, I'm not giving the full service to my patient. So the biggest challenge is actually lack of standardization. Of course, this is changing. Now there's a lot of interest in this assay. A lot of companies are trying to make a standard assay, and the organizations which work towards this the reproductive endocrinology organizations are moving towards making this a standardized way. But at this point of time, there are different assays, and all these assays do not crosstalk, and there is no standardizations, right? So remember, that's one of the biggest challenges as far as the progress of AMH is concerned. Of course, this I'm sure is going to be corrected very soon. There is a new developing assay which is known as a PICO AMH. It's an ultra-sensitive AMH which is used, developed by Ensch Lab. It's a US FDA approved device, assay for mainly for determination of menopausal status in women between ages of 42 to 62 years of age. Remember, we already have ultra-sensitive assays in other hormones, right? So you look at TSH, it's an ultra-sensitive TSH. AMH is still lagging behind, but it's a relatively new assay, and now we are developing an ultra-sensitive one. This is the only AMH test that is, useful to quantify the sensitivity and predict the menopausal transition. So it's very important in that sense. Remember, when you're perimenopausal, the levels of AMH will be lower, and hence you need an ultra-sensitive assay. Young women, it would make too much of a difference, right? And it is a limit of detection of about 0.182 nanogram per ml, which is 1.3 picomole per liter. That's why it's called as a pico AMH, because you detect up to 1 picomole per ml per liter, which is the reason why it is being used. The reason for pico AMH is that it will help improve our prediction of menopausal status, and that is useful not only for fertility outcomes but also in general as well. Does the use, and practical question, does the use of contraception have an impact on AMH level in women? Very important for you to understand, because again, we'll be dealing with this group very common. Studies have shown, and I've given one reference below, that hormonal contraception definitely does affect the AMH level, and you have the use of combined OC pills or vaginal ring and so on and so forth does impact the AMH. AMH levels tend to be lower in women who are using this contraceptive systems, right? So you have to keep this in mind, and again interpret in the light of that in that practical sense. Okay, let's look at the clinical applications of using of AMH. Let's talk with the the most important aspect today, that is AMH and the female fertility. Now, very important point, right? I think this, and if you don't take anything home today, this is the one you should take home today. Can AMH predict pregnancy outcome in women? This is very important. Answer is no, emphatically no, right? Remember, AMH is a very good marker of ovarian reserve, but it's not a marker for predicting fertility outcome or pregnancy outcome, right? Pregnancy, remember, depends on many factors. It's not just ovarian reserve, right? And I'm sure this room is well versed with that. This distinction should be very clear, because we often see patients being counseled with patients having very low AMH. Of course, there will always be an urgency to for pregnancy, yes, but at the same time, we do not give them a negative prognostication in that sense. You have low AMH, you have no hope, right? That is what we often hear, which I think should be a no, because women with very low AMH as well have delivered babies naturally, right? That's very important, right? So remember that AMH is a marker of your ovarian reserve. It's not a marker of your fertility or pregnancy outcome, and that's something we should keep in mind. In fact, this is what ACOG also agrees, and they've given this as a case, and they've taken this case directly from ACOG. And there's a 26-year-old woman who comes to you in your clinic, and she says that she wants to become pregnant in future, but right now she wants to focus on her career, which is very true. She also mentions that a friend recently had a test to check her egg count, and she wants to know how long she can wait to have a baby, right? A lot of patients come and ask, these things, and she's basically talking about the AMH. Would you offer an AMH testing to her, right? She wants to know, how long can I wait before I have my child? Now, she's worried at the same time, but she wants to delay as much as possible. And a friend told me, why don't you go and check with your gynec, and she will offer you a test, which will help you find out. Well, for this particular purpose, ACOG committee opinion says do not use it, right? AMH should not be ordered to counsel women who are not infertile about their reproductive status and future fertility potential. Please do not use this, right? This is a wrong use for a very useful test. This is a wrong use, right? AMH should not be used in fertile women to predict pregnancy outcomes, to tell them, when they can become pregnant and when they should not. This is, the ACOG does not recommend that this should be used for this purpose, because there's no data to suggest the same, right? The point being, right, use it in where it is strongly indicated. That's the point. Okay. Of course, like we discussed, ovarian reserve is not single factor. It depends on multiple factors. You have this AAFM model where it depends on the AMH, intrafollicular count, FSH level, and aging. And you always look at multiple factors into consideration. when you look at the ovarian reserve. So do not again rely just on one factor. Of course, if you put a gun on my forehead and say use one, I'll use AMH. But it's not a single factor, right? There are also other factors which can be used in practice. Now, AMH and AFC ideally should be twins, but they're not. Does AMH level always correlate with the intrafollicular count? Answer is not always, right? It's very important to remember this. AMH can be produced by follicles less than 2 mm, and they are GnRH independent, right? Remember, it's not dependent on this, though FSH does control it, it's technically independent. Whereas the intrafollicular count is measures the follicles more than 2 mm in size, and they are completely GnRH dependent, right? Now, in most cases, these are aligned, but in hypogonadotrophic hypogonadism in women, this is where there could be a dissociation, right? So this is where you look at it very carefully. So AMH may be normal, but AFC may be low, right? Because it's a GnRH independent and GnRH dependent, right? These women could have good fertility outcome with the use of ovarian stimulation. So again, the point here is that though ideally both are aligned, right? They're not always aligned, especially when you're dealing with hypogonadotrophic hypogonadism. You should really look at it in a more close way. We talked about this. We talked about Bologna criteria. I'll not go into too much detail, but this is the Escherich's definition for poor ovarian reserve, and it's something which is very useful. So advanced maternal age, a previous poor, ovarian reserve less than 3 oocytes, and abnormal follicular ovarian reserve testing that is less than 5 to 7 follicles, or AMH less than 0.5 to 1.1 is the Bologna criteria. This is an area in North Italy. Those who are Formula 1 fans, the Imola Grand Prix is just 30 minutes from here. This is where Ayrton Senna, the famous, Formula 1 driver, died. It's a very, it's like a mecca for Formula 1 fans, but also for, I think, fertility also, right? Okay. So then you have, of course, the other criteria. You have the Poseidian criteria. I'll not go into too much details of these. These are all, models created to predict the fertility outcome, predict the, poor ovarian reserve, and so on. I think, you're all well versed with this. The point being that AMH is an important integral part of all these criteria. Can AMH be used to, predict the response to controlled ovarian stimulation? This is important. Lee, in his study, has shown that AMH more than 3.36, or typically, if rounded off to 3.5, there is increased risk of ovarian hyperstimulation with, a sensitivity of 90% and specificity of 80%, which means that, again, it's a very useful test to see whether you are going to deal with perhaps some, miscalculations could occur, right? And Lee also found that if the AMH baseline is less than 1.08, again, 1, I think, would be the rough number to use. It's associated with poor, control ovarian stimulation outcome with 85% sensitivity and 78% specificity. And of course, a meta-analysis also done by Escherich and related bodies have also kind of endorsed this. They said that AMH is very important as a good baseline test to predict the power of the response, both high and low response to control ovarian stimulation. So this is, I think, this is the pillar of AMH. This is where it's most useful in a fertility setup. Like I said, Escherich does endorse the use of AMH for control ovarian stimulation baseline testing. And again, it's a very useful test in this scenario. And again, like I said, the cutoffs less than 1 suggestive of poor outcome, more than 3.36 or more than 3.5 suggestive of potentiality of multiple pregnancies. Okay, now, the unknown, AMH and the male fertility. Remember this, like I told you this, AMH is a marker of Sertoli cell function in men, right? This is the, again, this is another take home today, which you have to kind of understand, right? It's not a marker of Leydig cell function. Testosterone is a marker of a Leydig cell function, right? So keep that in mind. But so if you combine a testosterone and AMH in men, we actually get the complete picture of the male fertility, right? That's the interesting thing. In cases like, for example, in Klinefelter syndrome or varicocele, where there is Sertoli cell injury, which also happens, initially there is an uprise of the AMH, but then there is a gradual reduction of AMH, right? So if you're seeing a Klinefelter or a varicocele, which has been there for a long time, it keeps reducing further. Over a period of time, AMH then correlates with the fertility outcome in males, and lower the value, poor the fertility outcome. So I think this is where, again, there could be potential use. The problem, again, we do not have standardized cutoffs. We do not have standardized data, but it's an area of research, active research. Again, anybody interested in doing this, this is an area we should probably look at. And cryptorchidism undescended testis, this is where it's useful for us. the AMH levels, you have these young boys who come to us and they often refer to us, we have to kind of look at it, treat it, prognosticate them, everything, right? And AMH does correlate with poor fertility outcome in these cases as well. So it's a useful test in a sense to predict in men as well, not just in women. But I think, again, the problem here is that we still need to develop the standardized cutoffs. Does it have a role in pediatric endocrinology in general? Yes, we have one of the biggest challenges in young hypogonadal children is that AMH is useful for differentiating what is known as CDGP, that is constitutional delay, from hypogonadotrophic hypogonadism in boys. And CDGP is something where there is a delay in puberty, but eventually the child has the normal puberty, but it's late, right? In CDGP, the AMH is absolutely normal since the Sertoli cell function is normal, but in hypogonadotrophic hypogonadism male, that is the Coleman syndrome or its variants, the AMH level is low. So I think this is something you need to be useful. You can perhaps use that as a very useful test in young boys. So then, of course, the AMH use in PCOS, again, an area of extreme controversy, but an emerging area nonetheless, right? What is the basis for that? And I think this is where really AMH is really picking up in terms of an essay for both gynecologists as well as endocrinologists. Remember, AMH is produced by small antral follicles, and these are the same ones which you see on an ultrasound on a PCOS. And AMH hence is a very good marker, a surrogate biochemical marker for PCOS. You remove the human part of it, the operator dependence and so on and so forth. That is where it's useful. What about PCOS and fertility? Well, of course, there are no cutoffs which are strongly determined. So AMH can be used for deciding the ovulation induction protocol for infertile women. And like I said, to prevent ovarian hyperstimulation. This is again, these are the group of women where OHHS is, is very important. And I think, that is where again, AMH could be a useful test. Does it help in predicting the efficacy of ocipils? We already discussed that women on ocipils, the AMH will be lower. So it could be potentially useful, right? But the data is relatively limited. Remember, AMH, like I said, ocipils should reduce the AMH levels. But again, weight loss also should normalize the AMH in obese PCOS women. But then again, there is some role of metformin as well. But for predicting the treatment outcomes in PCOS, this is an emerging area of research, but we still don't have cutoffs once again, right? So again, this is an area where really, I think this is really useful in practice, but I think we are still far away from having a good data for that. The problem, I think, and I'll give you a solution to this as well. Remember, when you measure an AMH, you're not just measuring an AMH, you're also measuring the AMH precursor. Basically, what you get in an AMH report is the active AMH and the precursor, which is inactive, right? Which is a longer circulating half-life. Now, there are ways in which you can actually measure just the active AMH. And this could predict, what you do is you use, agent to sort of suppress the inactive AMH and just, remove that. And what studies are now found is that the active AMH actually has good outcome in correlation with the PCOS follow-up. So, at this point of time, we still have, again, emerging data, but what it looks like is that an active AMH may be a useful test for predicting PCOS treatment outcomes and also has good correlation with the other metabolic parameters like insulin resistance and so on and so forth, right? So I think perhaps this is the one where, you would really, see that, you start the patient, you measure the active AMH, you treat the patient with metformin, ocipils and so on. And then you see that, the active AMH is reducing. You say that perhaps the lady is doing really well on treatment. Is there an Indian data for diagnostic as part? We discussed this in the last meeting as well. Remember, this is a study which was published in Indian Journal of Endocrinology and Metabolism from AIMS. And what they found was that, they found that mean AMH was about 10 in the study group, which had PCOS versus 2.5 in the control group. And the cutoff about 5.5 was derived as a potential cutoff for use in AMH. So I think, again, in practice, remember, this might be a different assay from what your lab is using, but on a gross level, perhaps a level of more than 5.5 is very strongly predictive of PCOS. And perhaps this test could replace your transabdominal or transvaginal ultrasound from a diagnostic perspective in PCOS. Right? That's the broad idea. Okay. Finally, it has, of course, role in oncofertility as well. Again, it can predict. It's an important use, but like I said, it's still an emerging area. But again, something we'll really like to look at. Is it useful in tumors? Well, granular cell tumors, and Sertoli cell tumors in men. These are important because AMH, these are the ones which produce AMH, and they're important because they, of course, predict the outcome of malignancy, and higher AMH would mean poor prognosis. Some people say AMH also may be involved in the pathogenesis, remember, so that's the idea. Remember, it prevents atresia, right? And in cancer, you want atresia, right? It, kind of, evergreens it. It's also useful for detecting recurrence after surgery. These tumors perhaps have poor outcome as well. And remember, AMH is also size dependent. So up till 10 centimeter of granular cell tumors, you'll have high AMH. But if it's more than 10, you will have false negative values, right? So you might have AMH negative tumors, right? So it's a useful test. I've often been asked by, sometimes, keep doing AMH in PCOS women, and sometimes values are extremely high. And then, women read up on Google and they find that, do I have a tumor? Right? Answer is actually no, right? It's not a diagnostic test. It's more of a, in women with granular cell tumor, it's a useful prognostic test. So I just summarize some take-home messages. Remember, AMH is produced by granular cell in women. It starts at about 36 weeks of life. It's produced by Sertoli cell in men, which starts at about 9 weeks of life. AMH assay lacks standardization. I think this is the biggest hurdle. And this is the biggest challenge, and I think we should be able to solve this in due course. It can be measured at any time of the day, any part of the cycle, which makes it a very attractive test. Remember, OCPIL, women on OCPIL, the AMH values may be lower. It's a very important test for measurement of ovarian reserve, but in infertile women, and do not use it in normal fertile women. Do not use it for predicting pregnancy outcome, which is it is not used for. It's also AMH less than 0.5 to 1.1. It strongly suggests your ovarian reserve. More than 5.5 may be a useful test in Indian women for diagnosis of PCOS. So useful tumor marker for granular cell tumor in women and Sertoli cell tumors in men. Finally, if you're interested in more in endocrinology, we have this app free of charge. We have a lot of female infertility issues, and I think, like I said, it's cross specialty, right? Endocrinologists are equally interested and involved in fertility, both men and women, right? And I think, we talked about fertility preservation. I think it's very important. One more thing, you have a lot of pituitary tumors, and young men with pituitary tumors, I think neurosurgeons also need to be counseled that they also need fertility preservation, because they do make this men pan-hypopit and then keep chasing their, HCGs and HMGs and, keep giving them, and unfortunately the outcome may not be so good. So that's again an area where we really need to look at and work together. Thank you.
I am sure the audience was sitting in rapt attention for your talk as usual. So I need not say anything more. You have excellently highlighted the importance and the right take-home away messages of highlighting the importance of using it as an assay for only ovarian reserve and not predicting pregnancy. Thank you so much. Yeah, it was an excellent.
Three talks were excellent, and I would request the chairpersons to hand over the mementos to the speakers. Hital with the mementos. And I would also request Dr. Jagrati Patel and Dr. Kashmira Shah to come on the dais to hand over mementos to the chairpersons. And Dr. Kashmira Shah. Proceeding further, we will, before the start of the third session, as a customary, we would like to kindle the light of joy and proceed with our inauguration function. Take the lamp.
Jitendra,
So as they say that while the prayers go up, the blessings come down. So may I request today's dignitaries to come on the dais. The first would be Dr. Archana Dwivedi, President of our local Baroda Obstetric and Gynec Society. Dr. Deepa Patel, the Secretary of Baroda Obstetric and Gynec Society. Dr. Meenakshi Patel, who is the immediate past President of the State of Gujarat Obstetric and Gynec Societies. Dr. Vandana Patel. I would like to introduce Dr. Vandana Ben for the sake of the Dr. Durga Madam. She is an actively practicing obstetrician since more than 50 years, and she would put many of us young gynecologists to shame by the number of normal deliveries she still conducts today. I mean, she has, I think, probably 3 or 4 labor rooms running simultaneously with, of course, a lot of help. And she's a teacher to many private practitioners, despite being in private practice, never being in medical college. So, but many of us still regard her as a teacher. The next would be, of course, Dr. Durga Rao Madam, who is the co-founder and medical director of Oasis Fertility. For the sake of the audience, I would like to take a few minutes of time. So welcome, ma'am, and who has traveled all the way from Hyderabad to be with us on this August Sunday evening. And she's our, host along with Bakshi Madam. Next would be Dr. Krishna Chaitanya, who everybody has already been introduced to. He's a scientific head and clinical embryologist from Oasis Fertility. And I had heard one of the lectures of Dr. Krishna where he said once a man crosses 40, he has to be made to understand that even he can have problems, and it's not only the women who is at fault. And last but not the least, Mr. Sudhakar Jadhav, who is the Chief Operating Officer for Oasis Fertility. I have to make it a point to remember to call him Mr. And he's only non-medical person in the group today, in the hall today. And we will have a melodious prayer sung by Varsha Prapanna Madam.
Today I have selected a prayer for Saraswati Ma. Goddess Saraswati is a goddess of wisdom and knowledge. And whatever deliberations or learning we have had in any of the academic ventures never go wasted. They always help us to be more educated. हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। मुनियों ने समझी है, ऋषियों ने जानी, वेदों की भाषा, पुराणों की वाणी। हम भी तो समझे, हम भी तो जाने, अब विद्या का हमको अधिकार दे माँ। हे शारदे माँ, हे शारदे माँ, विद्या का हमको अधिकार दे माँ। तू श्वेत वर्णी कमल पर विराजे, हाथों में वीणा मुकुट सर पे साजे। मन से हमारे मिटा दे अंधेरे, उजालों का हमको अधिकार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। थैंक यू।
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश मतिं स्वच्छाहि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेतु मे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरु
Now, I would like to invite our next chairperson, our beloved Dr. Vandana Patel Madam. As rightly said by Dr. Reshmi Madam, she is the senior most gynecologist actively practicing and has the highest number of deliveries in private setup to her credit. She is also instrumental in steering our OBGY society year after year. Please welcome Madam. I also invite Dr. Archana Divedi Madam, Mrs. Versatile. She is a multitasker par excellence. She is currently the president of BOGS. She has been faculty at many state and national conferences and has won awards in dancing competitions. Welcome, Madam.
I would like to add, she has won many awards and also in dancing competition. She was the singer semi-finalist at Yuva Foxy. She was also awarded the Swan in the dancing competition, and she's made herself dances very well and makes others dance too, including me.
Thank you, Reshmi and Swati, for those kind words. And Dancing Swan was a real very good title which I received. I'm very happy about that. So going to the next session, chairing the session with Dr. Vanda ma'am is an honor to me at itself. And without wasting much ado, I extend my congratulations to Oasis Fertility Group, and a branch in Baroda itself is a very, very good achievement for the Barodians, and with Pakshi Madam heading the department over here, I think it's going to add new dimensions to the fertility patients and all of us who are present over here. Over to Vanda ma'am for introduction of Madam Speaker.
I would invite Dr. Durgavin for her next topic. Good evening, everybody. I have been given this privilege to introduce two stalwarts of IVF. They need no introduction, but a few words of appreciation from my side, if you would allow me. Dr. Durga Rao is a co-founder and medical director and an infertility specialist in the Oasis Fertility Center. She has been a specialist in reproductive medicine and minimum invasive surgery for over 26 years. The responsibility of bringing in the most advanced ART treatments and her experience, competence, personalized approach, along with extensive knowledge, understanding, and compassion played a very big role in the success of the treatment offered at this Oasis Fertility Center. She practiced in UK and Canada, underwent professional training in UK, and has got many papers and publications to her credit. Without wasting time, I would ask you, madam, to please start your topic.
I don't know whether I'll be doing justice to this topic because I've heard a couple of amazing talks this morning, rather this evening. One was about the ovulation induction, AGUI, as well as the AMH. But I'll try and see whether we can do justice to this. So the topic that was given to me by Madam Bakshi was, unexplained infertility, what next? Because frankly, when we are faced with a couple sitting in front of us, and we keep telling them we have done all these tests for you and frankly we haven't found anything wrong, then the only question is, you're telling us that everything is right, then why is it that we are not conceiving? And frankly, calling ourselves experts in front of that one simple question can really demean us. So how do we actually tackle this problem is what we have to look at. Now, when we are talking about the definition of unexplained infertility, there are three things and three aspects to this. One is they should have at least one patent fallopian tube. We have to document ovulation for them and ensure that the man has been assessed and we have adequate number of motile sperms. But when we are looking at this definition, there are a few things that haven't been addressed. And this is where the answers to the question that comes from the couple as to why is it that I'm not conceiving has to be looked into. And the three most important aspects is the definition actually does not tell us anything about the woman's ovarian reserve. Yes, the talk on AMH did tell us that, it is not a marker, AMH is not a marker to tell us whether she's going to conceive or not. But we have markers to at least plan their conception journey for them. And that is something that has not been included in the definition. We are not accounting for age. And that is one of the most important factors in terms of telling a woman what her chances of conception are. Third, again, something which has to be taken into account is the duration of infertility. How long have the couple been together? How long have they been sort of having unprotected intercourse? Because their concept of trying is very vague. What we don't understand, or rather what the couple doesn't understand, is if they have been living together and having unprotected intercourse, that actually broadens the amount of time that the woman could have conceived but didn't. So when they're telling us that they've been trying only for 6 months or 1 year, we have to first understand whether there has been a much longer time in which they have had unprotected intercourse. And frankly, when we're talking about the management of unexplained infertility, we have to take all of these into account. Now, AMH, I think, has been very well explained, so I will not go through this, but basically what we are trying to understand is, as one of the markers for ovarian reserve, as we grow older, obviously it decreases, and we have to make sure that we are planning the journey of conception much better. Now, what is the impact that we have in terms of age? Cumulative pregnancy rates over 2 years can be as high as 72 to 80%, and that is in women who are less than 35 years. But as they grow older, it actually comes down to 45%. And when you are adding in the duration of the union, then a further decline by at least 30% also needs to be added on. Now, again, when we are talking about the definition and what has not been included, the first question anybody asks is, you are saying that it's unexplained, but actually have you done a laparoscopy to understand whether there are any pathologies there? Well, again, this need not be a factor in terms of labeling somebody as unexplained. Laparoscopy need not be done. In the absence of evidence of tubal or other pelvic pathology, on initial less invasive investigations like a HSG or even a transvaginal ultrasound or even a HICO-C, laparoscopy is not warranted for us to diagnose somebody as having unexplained. Nor is it needed in terms of actually going further in terms of the depth of understanding unexplained. So now that we have understood what unexplained means, when a couple asks you, what is it then? How do you answer the fact that all our reports are normal, but you're still, we are still infertile. So this is where we'll have to be very honest with them and tell them we are only doing the tests that we know. There are so many other factors that are involved in creating a pregnancy for which we don't have the tests. So the question is, it is unexplained, but that doesn't mean that there is no problem. Unexplained in the sense that we have not been able to tell you or come up with one factor which says that you're not able to conceive, but that does not mean that there are no problems there for you to not have conceived till now. It's just that we are not able to identify, and we are not able to identify because we don't have the right tools to detect it. So which means that if a person is unexplained, they still need treatment. When do we need treatment? Well, the definition, as we have said, is once all those three factors are taken into account and we have at least given the couple a duration of a year to conceive, and they still haven't conceived, that's when we get into the picture and we start the management for them. Now, does this concept of waiting for a year hold good for everybody? Well, if a woman is less than 33 years to 35 years, yes, the concept of waiting for a year is valid. But once a woman crosses 33 or 35, then the concept of waiting for a year probably has to be revisited. So what are the management options that we have for somebody who has unexplained infertility? Well, the options are expectant management. We leave them alone for a little bit, or we do ovarian stimulation and timed intercourse, option of natural cycle IUI, ovarian stimulation plus IUI, or IVF. Now, we actually have 5 options. Which of these is actually appropriate for the couple sitting in front of you has to be looked into. And one most important factor is there's a difference between ovulation induction and ovarian stimulation. Ovulation induction is for somebody who's anovulatory and you need to give them medications to help them ovulate. But here, like we said, in unexplained, she is already ovulatory. It's only because she's ovulatory has she come into the bracket of unexplained. So for somebody who's already ovulatory, you're not going to be doing ovulation induction, you have to do ovarian stimulation, or what is sometimes called as controlled ovarian stimulation. Now, we saw about, during the talk of IUI, there was all other aspects as well spoken with. But when we are talking about unexplained, and when we are looking at the 5 options that are there in front of us, what option actually works? Well, there are lots of data out there who says that if you give them Clomid and you ask them to try naturally, it is same as letting them without any kind of medication or treatment. The results are similar. So frankly, there is no point in giving somebody Clomid and asking them to try naturally. That is a treatment for an anovulatory woman. That is not the treatment for an unexplained couple. What about letrozole and timed intercourse? Again, the answer is similar. This is a treatment for ovulation induction, not for a couple with unexplained infertility. But before we even go towards the management, I think one factor which we all should really take into effect is when we're talking about expectant management, it is not just a question of letting them alone and saying that, go ahead, go try for a year and then come back if you're not pregnant. I think that's an opportunity for us to actually understand whether there are any correctable factors when it comes to the couple. Smoking, alcohol, binge, any kind of recreational drugs. These are the factors that have to be looked into. What is her BMI like? What kind of diet is this woman actually consuming? Are there any factors that we can actually correct? And then you give them the option of waiting for a few more months before they go for management. Prolonged sitting, sleeping, tight undergarments, saunas, hot tub use, extended periods of driving for some men, and occupational exposure to high environmental temperatures. And most of these men, in fact, just a couple of days ago, a woman, comes charging into the OP saying that I want my husband to be seen. Why? Because she's been trying to tell this gentleman not to keep the laptop on his lap because he's working from home, and she's got fed up, so she decided she might as well get the deal done by the doctor. So these are some of the things that we have to actually address with the couple when the opportunity arises. Now, why are they important? Is because that when you have a woman with a BMI of more than 35, the time to conception is actually increased twofold. If she's underweight, in fact, it's worse, it's increased fourfold. Smoking, it actually reduces it by 60%. Alcohol increases it by 60%. Caffeine, now when we are talking about 250 milligrams per day, we are talking about 2 cups per day. Anything more than that is actually reducing your chances. Obviously, recreational drugs, the toxics and the toxins, as well as the solvents. Now, all of these have to be addressed. And in terms of BMI, even if the gap is pretty wide, you have a woman who's got a BMI of 39 or 40, and your ideal BMI should be less than 29. What do? At least get them to lose that 5 to 10% of their body weight, so that even that little change in their metabolism can actually help them. So even though we are calling them unexplained, these are the factors that can actually impact their chances of conception. Now, why did we say that it shouldn't be ovulation induction but ovarian stimulation? Why is it? What are the goals that we have to achieve? One, we have to increase the number of oocytes. She's naturally producing one oocyte every month, but that's obviously not helped her conceive. So when we are giving her medications, our goal has to be that she produces at least 2 to 3 follicles. If you give her medication, you do monitoring for her, you make her spend money, but you're still ensuring that she's just producing one oocyte per month, then you're really not helping her in terms of her goals. Correct subtle ovulatory dysfunctions and also improve implantation through hormonal effects on the endometrium. Now, what about IUI? Like how we said, giving them Clomid or letrozole and asking them to try naturally was no better than expectant management. What about not giving them medication, but just at the time of ovulation, you do an IUI? You might say, why IUI? Well, if there are any problems in terms of intercourse, if there are any issues in terms of ejaculatory dysfunctions, is that going to be an answer? Well, it's very, very clear that unstimulated IUI is similar to expectant management. What about ovarian stimulation plus IUI? Well, this is definitely better than just ovarian stimulation only or natural IUI. So if we have to manage this couple, you should be looking at ovarian stimulation and adding it with IUI. Now, Clomid and IUI, okay, if you do it 3 successive months, you have a pregnancy rate of 31%. Compare that to expectant management, which is only 9%. So you are allowed to increase the chances of conception by giving them Clomid, but adding on an IUI with them, not timed intercourse. Clomid plus IUI is equal to letrozole plus IUI. Next, gonadotropin with IUI, way better than just Clomid with IUI. 32% versus almost 10%. But gonadotropins obviously has its advantages and its disadvantages. Advantages, like we have seen, the success rates are way better than just giving them Clomid, and even though you're adding on IUI with it, the ovulation rate is better and so is the conception rate. But obviously we have to be very careful about the fact that multiple pregnancies are much higher, OHSS is much higher, and it definitely requires much more monitoring, and you have to have extremely strict criteria for cancellation. Anything more than 3 follicles, you have to be very brutal in saying that this is the time then we are not going to be going ahead with continuing your treatment. Obviously expense when you're comparing it to the other modalities. Now, when we are talking about the oral injectables, everything associated with IUI, is there anything else that you can do? Well, we have had lots of studies which tell us that once you're doing a HSG with an oil-soluble, solvent, then it increases your chances of pregnancy on a natural basis. That concept actually has helped some of the couples with unexplained infertility as well. In fact, there was this paper that came in which looked at injecting some amount of lidocaine. It's actually tubal flushing. And the concept was the lidocaine, like how the oil contrast media was used for HSG, lidocaine also has some amount of immunogenic potential which is helping in terms of improving the chances of conception in unexplained. Now, like we said, it's very important to have very strict criteria when we are talking about how much should we allow in terms of the number of follicles. If you have just one follicle, it's almost as good as a natural cycle, so that is less than 10%. If you have 2 follicles developing, it's close to 15%, which is slightly better than natural. If you have 3 follicles, it is closer to 20%, which is what is ideal. If you go more than that, your pregnancy rate still is not greatly increased, but your risks are increasing, which is multiple pregnancy as well as OHSS. What about the stimulation protocols? Well, like we said, if you're doing a natural cycle IUI, which ideally should not be done, your chances are only about 3%, which is why we suggest that it's expectant management is better. If you're doing Clomid plus IUI, it's almost 10%. Clomid plus HMG with IUI increases your chances. And if you're doing only a gonadotropin stimulated IUI, that gives you the best success rate of almost close to 20%. Then comes the question of timing. When is the best time for us to do an IUI? Well, anything within 36 hours from your trigger is good enough to do an IUI. Some people do it at 24 hours. Some people do it at 36 hours. Some people do it at the time of ovulation, whenever it is, which means that they keep scanning to ensure that ovulation is done and then do IUI. None of these have actually shown to be better than the other. So any time within the 36 hours from the trigger is when an IUI can be done, and it seems to give us the same kind of success rates. Now, this is a very valid and a very important question. How many cycles would you allow? As this graph very eloquently puts it, going beyond 3 to 4 cycles in a woman, in a couple, is actually not increasing their chances. It increases up to the 3rd or the 4th cycle, but after that it plateaus. So going beyond 3 to 4 cycles in a couple is really not improving their chances. In fact, you're just delaying the chances of conception for them. This FAST trial, which was done for women who were less than 38, very clearly looked at the different options. And here what they did was, they did 3 cycles of Clomid with IUI. If they didn't conceive, they moved on towards gonadotropins with IUI for another 3 cycles. And if still not pregnant, move towards IVF. So medications, injections, and then IVF versus Clomid IUI and then move straight for IVF. And what they found is the time to pregnancy was definitely shortened by the second aspect, which is do IUI for 3 cycles, no conception, move straight for IVF. In fact, what was also very interesting is they found the second option cheaper for the couple. It is not just the time to pregnancy, but the fact that the second option was also cheaper for them. Now then, that was a study which looked at women who were less than 38, 39. What about the older women? You might say, anybody older than 37, 38, why are you even considering IUI? Well, this particular study actually looked at the cumulative pregnancy rates. And what they found was Clomid with IUI almost gave them a 20% success rate. FSH with IUI gave them almost a 17, but an IVF gave them a 50% success rate. So if you're looking at a woman who's above 37, 38, IVF should be your choice. Now, this again is a very, common question asked by couples. You have given us medication, you have ensured that we've ovulated, you're also scanning to ensure that we have released the egg, you're doing the sperm, you're putting the sperm right into the uterus, and I've still come back having had a period. Why? When you said that everything works, everything was fine, why haven't I conceived? Well, these are the factors which the treatment does not tell you. You are putting in a total motile sperm count, but you have to ensure that it's more than 10 million. That's when you get the best success rates with IUI. You have to ensure that the sperm has the capacity for at least more than 70% to be surviving beyond 24 hours, which a sperm analysis does not tell you. Normal sperm, even if it is less than 4%, I don't think is a major problem here. But what is important is their motility and their survival after 24 hours. If you have inseminated smaller amount of sperm, it's not going to work. The most important things which are there in our hands, but we sometimes don't concentrate on, is the delay in sperm processing, which should be done within 30 minutes. If you cross that, the chances of IUI are going to decrease. And after processing, actually doing the IUI, if it crosses again an hour also, you're actually reducing their chances. So what's there in our hands are the last two factors, is do the sperm preparations on time and do the IUI on time. The other causes of IUI failure is oocyte quality, which again we will not know. Sperm quality, again, we won't know in terms of the acrosome reaction and the zona penetration. The tubal ciliary motility, yes, HSG only tells you whether it's open. It doesn't give you the functionality of the tubes. What about fertilization? Can you ensure it? No. Implantation? No idea. Aneuploidy? No idea. So there are so many questions that IUI does not answer. What will you do if you have done IUI and it's failed? What is the next step, which is what the question that we started off with. The first thing that you have to do if an IUI hasn't worked for them is to do the sperm function tests. Here, because we say that the sperm analysis, which is the first test that we do for the male, does not give us the complete information at all. In fact, it has a poor prediction of fertility since only 50% of infertile men have normal sperm parameters. They are actually fertile. They have procreated, but if you look at their analysis, 50% of them only will have normal sperms. The rest will still have abnormal parameters, but it still was good enough to get pregnant. What about morphology? No connection in terms of outcomes. And the specific sperm dysfunctions like the acrosome reaction, the zona binding, none of this has been evaluated in a sperm analysis. And again, each lab can be different. You tell him he's got a count of 6 million, he'll come back with a report from somewhere else and say that it is 18 million. What about the day-to-day variability of sperm parameters? It's not just about the variations in the lab, it is the variation that the same man might actually produce. So the sperm function tests were developed to detect abnormalities in terms of the sperm survival, the transportation in the female genital tract, the different step of fertilization, the prediction of fertilization, as well as the pregnancy rates, as well as targeted therapy to reverse infertility. So the sperm function test aids us in terms of giving us at least some of the answers to the questions that we have. What about laparoscopy? Well, laparoscopy in its place when we are talking about unexplained comes in only if they have had 2 or 3 cycles of an IUI. It has failed, but they still would like to consider IUI further. And the ovarian reserve tests are actually helping you, or rather enabling us to consider more than 2 or 3 cycles of an IUI. Why are we doing laparoscopy? When frankly, we said when the definition itself does not deserve a laparoscopy to be done. We are doing that because at least 60 to 70% of these people who are called as unexplained, after laparoscopy, you will find a pelvic pathology, of which endometriosis is at least 30 to 40%. So they no longer tend to be unexplained. You have found some amount of pathology in at least 70% of them. So place of laparoscopy in failed IUI in unexplained is both a diagnostic and therapeutic. It also helps you evaluate the endometrial cavity, and there is higher chances of pregnancy following laparoscopic treatment, but that's only if it is a stage 1 to 2 endometriosis. And stage 1 to 2 endometriosis, not just on diagnosis, you have to actually eliminate whatever is visible of the disease in the peritoneal cavity, which means you're excising all the deposits of the endometriosis that you're seeing. If you're able to do that, then your chances of pregnancy are higher. In fact, this is what was very eloquently described in this article. What happens if IUI fails? You have done 2 or 3 cycles of IUI, you have done a laparoscopy, you have treated her, and you continued with at least another 2 or 3 cycles of IUI, then what? It's IVF. IVF, yes, it's invasive, it's definitely expensive, but the shorter time to pregnancy is what we have to look at here. Should it be IVF or should it be ICSI? Frankly, when studies were done, they found no differences in the clinical pregnancy rates or live birth rates when comparing conventional IVF or IVF with ICSI for couples with unexplained infertility. In fact, ICSI is suggested only if there's a prior history of failed fertilization. But obviously, in our scenario, although all the studies are saying this, for somebody who's had a long duration of infertility, you have tried IUI, they haven't conceived, they're going for IVF after, struggling to gather their finances and coming forward, would you say that, the results are going to be same, I'll do IVF? You'll probably at least go to the extent of saying, I'll do a sibling. At least I'll do half IVF, I'll do half ICSI, at least so that you're not left with having a completely failed fertilization and then end up doing a rescue ICSI. But again, before you do IVF, what is very important is an assessment of the uterine cavity has to be done, reassessment of your hormonal balances, evaluate the ovarian reserve so that you can plan the protocol. As was said, if the AMH is very high, you will have to look at the protocols that are suitable for hyper responders, or if she's a normal responder or a poor responder. Sperm function test, pre-treat them with antioxidants like myo-inositol and vitamin D. So to optimize IVF, you have to look at these three factors. How do you optimize the oocyte? How do you optimize the sperm? How do you anticipate failed fertilization, and what your options are? Why IVF and ICSI? Now, when they say that you have done IUI for us, it has failed. How do I know IVF is going to work for me? At least we have some of the answers which IUI didn't give us. And that is, you're able to assess the quality of the oocyte, the sperm, and the embryos, which an IUI you weren't able to do. It overcomes the cervical factor, which IUI sometimes can help, but this is better. The sperm and the egg interaction defects can also be seen. Sperm-egg transport defects can be corrected, and fertilization failure, you have the option of doing ICSI, and you can also detect any problems in terms of the cleavage. So, algorithm, if you have a woman who's less than 33 with a good reserve, normal semen analysis, you probably, in our scenario, in India, you probably will try TI for 3 or 6 cycles. You will go on towards IUI. If IUI fails, IVF. In IVF, again, the concept is to put back 4 blastocysts at different intervals. I don't mean 4 blastocysts at one transfer. That is why it's said it's separate attempts. And if she still hasn't conceived, then it's recurrent implantation failure, for which you will have to go ahead for PGT and ERA. So that would probably give you the success rate that they deserve. So even when we are saying, IUI, we are going for IVF, I think we have to go through this particular algorithm with them so that they know what to anticipate and what to expect. If the woman is older, she's got a borderline or a poor ovarian reserve, and there's borderline or poor sperm parameters, if they've had no prior treatments, because sometimes it gets very difficult for the woman who's had absolutely nothing done, saying that you won't go straight for IVF. In those people, probably you will consider at least 2 cycles of an IUI. If no pregnancy, then you're looking at IVF. Or if they've had an earlier fertility treatment, you would go straight for IVF. And in IVF, again, the concept is at different attempts, you go for 4 blastocyst transfers, no pregnancy, then you're looking at PGT and ERA. So summary, minimum number of IUIs 3, maximum number of IUIs, can go up to at least 6, but you have to understand the ovarian reserve and the age of the woman before you plan to go more than 3. If the reserve is average and the age is between 33 to 35, stick to just 3 IUIs. If below average reserve or she's above 35, IVF is better. But if they've never had any treatments, they are treatment naive, you can go up to 2 IUIs. If poor reserve and she's above 35, it's IVF ICSI. Ovarian reserve tests. Some of the parameters that we have to look into is an AFC. For me, more than AMH, I think I rely more on an AFC because that is something that we can see. AMH to me is a tool that you can use to counsel the patient, because that's a piece of paper that she can show anybody and they'll give her the same probably answer. But a scan is something that gives me the confidence to know that what is the volume of the ovary, how many follicles are we seeing, what kind of protocol would work for her. That helps me, but an AMH probably helps the woman. If an AFC is 15 to 20, up to 4 cycles of an IUI. If it's less, up to 3 cycles of an IUI. If lower than 10 AFC, probably limit the number of IUIs and consider IVF. When should IVF be considered soon? Well, when she's above 35, AMH is less than 2, AFC is less than 10, FSH is above 8 or 9, severe endometriosis, adenomyosis, and fluctuating sperms. Now, this is one paper which actually has opened our eyes when it comes to unexplained. Decline in ovarian reserve may be an undiagnosed reason for unexplained infertility, which is why when you see a scan report done by a radiologist or in radiological centers, normal ovaries, you always have to suspect using that report and advising a woman. I think doing an ultrasound scan, a vaginal scan by a fertility specialist actually gives you so much more information in terms of planning her fertility journey. Hardly ever do we see normal ovaries nowadays. We either see PCO or we see low reserve. The amount of normal ovaries probably we can count. Now this question, this conundrums about whether it should be IUI or IVF, we still don't have answers, as you can see from all the data. We are still waiting for this trial to come back and tell us, and this is called as the FIX study, which actually has been registered, but the results are not out yet. They haven't published the results yet, which is actually going to tell us for the unexplained, should we consider IUI or should we go for IVF? Is it going to make it more economical, or does it have any other information? Well, let's wait for this and see whether that's going to answer some of the questions that we have. Thank you very much.
Thank you, ma'am, indeed, for highlighting the points. Especially, please come and join us. Salient features, because this is a big question mark when the patient comes in our OPD, and getting to the points very nicely, step by step, was a great take-home messages over here. You rightly said that expected management should never be forgotten. With other modalities and controlled ovarian hyperstimulation is a good answer for them. Thank you for the enlightenment, ma'am. And over to the
We invite Sushma Bakshi for the next topic, which is fertility preservation, need of the day. Sushma doesn't need any introduction. She's a Barodian. I can only say that she's a good friend of mine. And in discussions about patients, many times we end up with differences. As I belong to the old school, rely more on my eyes, ears, and hands. But finally, we convince each other. Well, she is the head of the Oasis Vadodara organization, WHO fellow from Harvard, Boston. She was an ex-assistant professor at Medical College, Baroda, where she has taught many students. Past DOG's president, past SOGO president, and she is the founder of Baroda Society, Sukesha and Gopal fertility clinics, and she is very, both the hospitals are very close to her heart. And she still manages patients at those hospitals with little low cost. So, Sushma, we would like you to give us your talk.
Thank you, Vannaben. Coming from you makes the things more special to me. Are you all enjoying? Because I'm not hearing any of you. We have been bombarding you with some of the difficult topics, and believe me, talking about unexplained infertility is like playing a googly ball in infertility. And I think, Dr. Durga, you have made a sixer out of it. So, and I'm going to talk on a little different topic. You people might think that when we are struggling to make normal people pregnant, addressing the issues of fertility preservation in cancer and other things, why do we worry? But fertility, having a child itself, is one of the major objective of a humankind, and if it is not going or reaching to the people who need it, whatever the reason, well, we are failing in some way. OBGYN specialty has given so many subspecialties, and it is a progressing fraternity. This kid, fertility preservation, is sitting at the corner waiting for us to adopt it. Well, it's said that difficult roads lead to beautiful destinations. Friends, this road of fertility preservation is bumpy road, but if it ends into a destination like having a beautiful baby, believe me, it is worth it. This fertility preservation is naturally occurring in everybody. But when in abnormal conditions, there is compromised fertility in some of the man or women, we have to treat it. And our treatment is by way of saving their gametes, the sperm, oocytes, embryos, and reproductive tissue, so that that person can achieve the biological child when he or she desires. It's not a very new thing. For last 50 years, it is something like fertility preservation at a low level was going on. Like when we were doing surgeries, we were trying to see that the pelvic organs are respected. We were not doing unnecessary oophorectomies. We were not doing unnecessary hysterectomies. But, and semen banking itself, the preservation of semen was going on. But in last 20 years, friends, the ART specialist and people like Krishna and Abhishek and other, they have given a new way to fertility preservation by way of preserving gametes. When we should go for fertility preservation, as per the ASHRAE, the indications for fertility preservations are when somebody is young and is suffering from cancer. Some of the non-oncological conditions, medical conditions are included in this. And the new facet which has come, that desire delay in childbearing because of social reasons. So what the various sorry, the first and foremost, let's suppose in a pre-pubertal girl, less than 12 years or 11 years old, who, if she has something like cancer, like she's having leukemia or brain tumor or Turner syndrome, what can we offer her? One of the things which we can offer her is ovarian tissue cryopreservations. Not only that, the women in whom we cannot wait for ovarian stimulation to preserve the oocytes and oocyte retrieval is not possible, they also can go for ovarian tissue cryopreservations. This was a study of infertility and sterility of 2021, a review of leading European center where a series of 285 women underwent transplantation of cryopreserved ovarian tissue, and it said that at this early stage of development of ovarian tissue transplant for restoration of fertility, the results are encouraging and it does demonstrate clear potential. However, appropriate consent and ethical consideration is absolutely necessary. So I would like to show over here that ovarian tissue cryopreservation, what do we do in that? So in this picture, what you are seeing is the patient is subjected to ovarian tissue removal by way of laparoscopy, and this ovarian tissue or whole of the ovary, depending upon the need and the indication, that is cut into the small sizes of less than 2 millimeter, and those slices of ovarian tissue is cryopreserved into the vials, and they can remain cryopreserved as long as it is wanted. So whenever ovarian stimulation and ovarian retrieval is not possible, in those cases, like younger girls or like those who have to go for chemotherapy or radiotherapy very fast, they can go for ovarian tissue cryopreservation. And this, once the patient is out of the disease and is reasonably good, that is the time orthotic transplant or autologous transplant of human ovarian tissue can be done. It can be kept into the mesosalpinx, as you can see over here. It can be done on the ovarian surface. You can stitch it. Those tissue is thawed and then stitched over there, or you can buy half the ovary and put it in the middle. And this orthotic transplant really helps. About 100 live births have been reported. Pregnancy rate is around 33%. Delivery is 25%. What is more important is that active endocrinal function, these patients do not suffer from menopausal symptoms. And only thing which is negative over here is that the mean ovarian graft longevity studied so far is up to 7 years. There is a risk of reintroduction of malignant cells if at all the systemic cancer disease is there. Only thing we must remember is that ovarian tissue cryopreservation is still experimental, and it is not accepted by ASRM and ASHRAE as one of the standard line of treatment. So when orthotic transplantation is not possible, when pelvis is not suitable for near uterus transplantation due to scarring or radiation, it can be transplanted on abdominal wall or forearm skin, which is shown over here, and that can work. That can be stimulated, that ovary can be stimulated. You can retrieve the eggs from them and you can make the embryos, and then patient can conceive, which is known as heterotropic ovarian transplant. So ovarian cortical tissue, when you have preserved, you can either go for orthotic transplantation or heterotropic transplantation. Those cases in whom this kind of ovarian cortical tissue, when we are suspecting that there might be some cells, so in those cases IVM is one of the option. So you can take out the eggs from that cortical tissue, from the primordial follicles, or inherently before going for any ovarian removal, you can take out the primordial follicles. However, safety of IVM in cancer patients are less, and implantation rate with IVM is low. But in 2020, the first birth was achieved after fertility preservation using in vitro mature oocytes in women with breast cancer. This lady was 29 years old, was diagnosed having left-sided breast grade 3 invasive ductal carcinoma. 7 immature oocytes were retrieved. Her AMH was around 2.9. She underwent transvaginal ultrasound, and after 5 years, she opted for pregnancy. Out of 6 M2, 1 day 3 embryo was gained, and it was transferred, and she conceived and delivered a healthy baby boy at term. So what I want to say is that the research is going on, and there are so many experimental various methods, but it gives some hope to this kind of patients. Regarding post-pubertal females, how do we do fertility preservation? So whenever there is time and safety for ovarian stimulation, these things are easy, that we can go for oocyte retrieval, we can go for oocyte freezing and embryo freezing in them. I tell you a case of 32 years old, recently married for 1 year, diagnosed having breast lump. She was having ductal carcinoma. Her maternal cousins were having breast CA positivity. She underwent surgery in July 2021. She came to us in August before chemotherapy. Fortunately, she was a geneticist. And after having counseling and discussion with her onco team, her IVF and embryo freezing was done. We are aware of the fact that chemotherapy and radiotherapy, they do create problem with the oocyte quality and embryo quality. So before that, if we have oocyte frozen or embryos frozen, it gives us better success rate and survival rate. The National Cancer Registry in India says that about 1.4 lakhs cancer patients are diagnosed in their reproductive years. So I want to emphasize that there is definitely need for fertility preservation. This graph shows that the risk of radiotherapy and chemotherapy, the uh, upper one shows that normally how the ovarian reserve is going down, but when we subject those patients to radiation or chemotherapy, the further fall in the ovarian reserve does occur, and the female loses lots of primordial follicles. So when we are going for risk assessment with oncotherapy, we must know that which are the high risk oncotherapy agents, which are intermediate risk, low or no risk, and unknown risk. And this kind of paper should be there in front of you, because it is the OBGYN people only who can diagnose cancer early and can give hope to this patient. So when we are doing this, it is not a one person's job. Who should constitute the team in taking balanced decision? It we should have medical and surgical oncologists, reproductive endocrinologists, urologists, obstetrician and gynecologists, and fertility consultants. This team should discuss and decide about fertility preservation in patients. The good thing about cancer therapy is that now long-term survival is possible. Advances in cancer diagnostic and treatment really helps us diagnosing cancer earlier. More effective fertility preservation techniques are available. We are having almost 80 to 90% of survival rate after thawing, and available photoprotective agents are also there. So our aim is to improve quality of life. How to minimize effect of cancer therapy on fertility? We can lead shield the gonads, surgical transposition we can do of ovaries whenever radiation is to be given to the pelvis, and especially in cervical cancer, before radiotherapy, ovariopexy definitely helps. The long-term outcome of controlled ovarian stimulation in these cancer patients, there is no difference noted in mortality, recurrence, or ovarian response. No need to consider cancer type or controlled ovarian stimulation protocols for oocytes. These are the patients in whom, when we are going for ovarian stimulation, we need to go for, we need to see that E2 levels are not going very high. OHS is to be avoided. So mild stimulation is to be done, and I mean, definitely letrozole and gonadotropin is a good choice for stimulation with antagonist protocol and agonist trigger is the way to do. And another advantage which we can take, because the time is less, so random start or luteal stimulation is to be advocated. So these patients for whom we have preserved these embryos or oocytes, when they should go for pregnancy after the cancer, the conventional wisdom is to wait until patient gets through the period of highest risk of recurrence. So that phase has gone, then definitely one can consider pregnancy for her. Ultimately, our aim is to provide quality of life and not only life. What is more important for all of us is the time sensitive referral. And unfortunately, from various studies, it has been found that fertility preservation services are rarely offered or even discussed with the patient before starting cancer therapy. The third scenario is that social freezing, that a 30 years old lady, very well educated, and she comes with a request. She is not married, but she says that please preserve my eggs. I mean, something which I think Dr. Krishna has talked. Her AMH is 1.8 and AFC is adequate. Her mother had early menopause, so she was worried. So should we go for fertility preservation? Should we offer her that? Well, these days, career priority, delay in marriage, excessive contraceptive use, financial reasons, education related delay, all these. A husband sometimes is out of uh, the country. And sex affirmation procedures like gender dysphoria. We have a patient who wants to convert herself from female to male, and at that point of time, we have offered her that, do you want to preserve your oocytes, because we are going to next month we are going to go for her oophorectomy. So she is thinking about it, because age is very important, and this lady has really considered it and thought of it and has come to us. Uh, the reason for age being an important is that with increasing age there is a risk of aneuploidy, decreased fecundity, increased miscarriage rates, and higher incidence of menstrual disorders after 35 really puts a problem. Amongst non-onco conditions, all are there. These are all conditions which lead to premature ovarian insufficiency because of the disease itself. The worth mentioning is ovarian endometriosis, and it is because all of us are seeing the cases of endometriosis, and fertility preservation in women with endometriosis is a must, and it can be offered by oocyte or ovarian tissue cryopreservation. Uh, on individual basis, it is to be considered, especially those who are having bilateral and ovarian endometrioma. And comparatively, oocyte and embryo cryopreservation are the standard methods, accepted methods for this. We have done, Vandaben knows that we had a case sent by her only. She had bad endometrium on one side. In other ovary, there were 3 to 4 follicles, and she wanted to go for surgery. So we offered her that you better go for IVF first. We preserve your embryos, and then you go for the surgery, and so that we can transfer them later in you, because post surgery we all know that AMH level drops. So a word about GnRH agonist, it is still an offline treatment as on now. There are studies which say that it is excellent and it helps. However, not there are conflicting data of it. Those who have not preserved their oocytes or embryos, for them the options are donor oocytes or sperms, surrogacy, or adoption, and that should be made very clear to them, or those who cannot go for fertility preservation because of the disease itself. These are the options for them. So to conclude, fertility preservation is a vital issue for individuals when future fertility is compromised. Multidisciplinary approach is essential. All options for fertility preservation should be discussed. I think that is the bottom line message. It should be discussed before initiation of gonadotoxic therapy. Embryo and oocyte freezing are standard fertility preservation methods in post-pubertal females. Ovarian tissue cryopreservation and IVM are still experimental. Ovulation stimulation protocols don't affect cancer recurrence or survival. That should be borne in our mind. And age-related delay in fertility patients should be safeguarded and counseled. So, as a fertility specialist and the gynecologist, a delicate balance between the safety and the risk is to be kept in mind. And something which is very useful to her, going to be helpful to her, is to be offered after thorough discussion. In oncomedicine, disease-free state is becoming a reality in a significant number of young men and women, and that is why timely action is a must. With this, I thank you very much. I hope that this was something a hatke topic, and but it will be of use once you see that, and once the eyes see, mind will think about it, and possibly will be able to offer this kind of services to the patient who are really needing it. Thank you very much.
It is the Sri Ganesh to a very good apt topic, and fertility preservation, I think it is the new era thing which is going to come up in coming days as people are desirous of late marriages, career, as you rightly said, ma'am. So thank you for enlightening and doing the Sri Ganesh to this topic, which was really hectic, but will be a current scenario in coming days. Thank you.
And I would request the chairpersons to hand over mementos to the speakers, Dr. Vandna Ben to Dr. Durga Rao Madam and Archana to Dr. Sushma Bakshi Madam. And I would also request Dr. Ketki and Dr. Alpna Gohil to come up on the stage to hand over mementos to the chairpersons. Ketki and Alpna Ben. So the next session would be our much awaited panel discussion.
Podium mic.
Yeah. Till the panel is getting ready, I would like to make an important announcement at this outset, because we are, as a Barodian, getting the opportunity to hold the National IMS Con in February. So please block your dates for 11th, 12th, and 13th of February. And we are also offering the 10th city visit during that, and very lucrative workshops, which we are looking forward. And without your presence, it's not going to be a success. So there's a standee outside. Please block your dates. Thank you so much. And I take the pleasure of announcing this because Madam is the founder secretary of our menopause chapter, and now we are a society over here. So congratulations, ma'am. Your baby is growing well. Thank you, everybody.
Thank you, ma'am.
So this is a president who's after money right now. So we are going paperless. So please visit the broadcast group of Baroda Obstetrics Society to know the new details of your annual fees deposition, because last date is 31st of December. So please do make use of the new technological advancement, and you can pay the online fees to the BOJS team. Thank you so much.
We now move on to ANC from ART. And to manage pregnancies post ART, we have a panel discussion which will be moderated by Dr. Narendra Gajjar. Welcome, sir. Dr. Narendra Gajjar is president of Navsari Obstetric and Gynec Society. He has been past president of Gujarat State OBGYN Society. He has received many prizes for academic performances. He has demonstrated NDVH in many surgical workshops also. Welcome, sir. I'm sure you will make the panel discussion very interesting.
We'll invite all the panelists. The first panelist is Sandhya Harpale Madam, who's an MD OBGYN and in private practice since 35 years. She was past president of Baroda Obstetric Gynec Society. In her tenure, the society won the Best Society Award. And her areas of special interest are high-risk obstetrics and sonography. And I know that she has been managing many of the high-risk ART pregnancies, which have been sent to her to the Oasis Center. The next panelist is?
Yeah, the next panelist is Dr. Pallavi. She's past president, Pallavi Satarkar. She's past president, Baroda OBGYN Society. And right now she's secretary of Indian Menopause Society, Vadodara. She is trained for gynec endoscopy at Kiel, Germany. And she runs Anant IVF Center in Vadodara.
And the next panelist is Dr. Haresh Shah. Very simply put, he is 108 of the Baroda Obstetric Gynec Society. He's a stress buster. He's an oncosurgeon and an endoscopic surgeon. And anybody who has a PPH or a high-risk cesarean section, Haresh Bhai is always on his toes for all of us. So it's better to call Haresh Bhai rather than call a lawyer or a police officer in the middle of the night.
I now call upon Dr. Firoz Bhuvar. He's director of Khushbu Fetal Medical Center, and he's awarded health minister. He has been awarded by Health Minister of Gujarat for his work in the field of OBGYN. He has conducted 2 WHO studies which have been published in the Lancet.
And Firoz Bhai is also the sonologist who diagnoses all the complications in the pregnancies. So he's another go-to person for all of us. The next panelist is Dr. Shonali Agrawal, who is an associate professor with the Medical College of Baroda. So at least for me, whenever I have any trouble with any patient and the patient is not affording it for private practice, so we push them all to the medical college. And Shonali is always a person who I call up. Her fields of interest are reproductive endocrinology and high-risk obstetrics.
Dr. Purvi Patel is the next panelist. She's associate professor and unit head, Medical College, Baroda. She's recipient of AOFOG Young Gynecologist Award, and she is also the recipient of Best Paper Award in 2018 from Journal of Obstetric Gynec of India.
And the last panelist is Dr. Yuvraj Jadeja. I would read out his CV in details. He is an MD with OBG because he's new to our society. He's an MD with obstetric and gynecology. Done his diploma in advanced gynec endoscopy with France, the ISAR Aspire Fellowship in Reproductive Medicine from Japan, and Fellowship in Reproductive Medicine from Kiel School of Germany. He's a medical director, Nimaya Women's Center, Vadodara, and fertility in charge with Dheeraj Medical College. So welcome Yuvraj, welcome all the panelists, and Narendra sir, the floor is all yours.
Good evening, friends. At the outset, I would like to thank office bearers of Baroda Gynec Society and Dr. Sushma Madam for inviting me here to speak as an obstetrician. The work of infertility specialist is over. Patient is expected to be pregnant or patient is already pregnant. And we have got a team of sonologist, means fetal medicine specialist, obstetrician, Dr. Sandhya, who is working since many years, Dr. Pallavi, Dr. Haresh Bhai, helping 108. Once I spoke in Surat about 108 of cervix. So cervical conditions where 108 is needed. So Dr. Haresh Bhai is with us. Dr. Shonali and Dr. Purvi Madam, they are the real workers who have taught obstetrics to so many students, and they are really helping the whole community to reduce the maternal mortality and morbidity as well as neonatal problems also. And Dr. Yuvraj. So once again, I welcome my team, and they are the experts. Dr. Pallavi, do you believe that incidence of ART pregnancies is really increasing, or these are the patients who are not able to afford, that is why the incidence appears less?
No, it is not. It's like two sides of the same coin. The incidence is not less. The incidence has definitely increased over the year with the advent of technology, and as well as with the availability of the information to the patients rotated.
Okay, fine.
It has also increased. The incidence has also increased because the more women in elderly age group, they become pregnant. They want fertility treatment.
Dr. Yuvraj, Sushma Madam, and all infertility specialists who are here in the hall, what is the reaction of a patient who has been under your treatment, rather treatment of many doctors, and once you announce that her pregnancy test is positive? What do you feel? What do you feel your reactions?
Yeah, please. Sir, firstly, the consultant by themselves are very happy then the patient becomes happy.
Consultant has
Right from
already-
the front desk staff, everyone
Yeah.
is like beta HCG, beta HCG. So the first thing is like,
Uh-huh.
a very practical thing. Let us put the evidence and everything a bit aside, but the consultant is very happy, and because then you get connected with the patient on a very practical terms.
It depends on whether there is a strong line or a weak line.
Okay. Say strong line, sir. But you will say that patient is pregnant, okay? Do you believe that is she pregnant? With positive pregnancy test, road is going to be very smooth for her. Patient is elated, and you feel that your hard work of years have culminated in something fruitful.
Yes, sir. I think that's the catch. What you said. I mean, everyone is very happy because infertility patients have researched so much about infertility. The moment they get pregnant, now they are scared of pregnancy.
So
But
can
now
you say-
the real journey starts.
Yeah, this journey starts from here. And it is our duty as an obstetrician to see that road is not so smooth and so easy, especially for these patients. And we do not want to see that picture. Right?
Yeah, fair enough, sir. Because I think with practice and with more of experience and the more patients you deal, more couples you deal with, a positive pregnancy test or a positive beta HCG test, you know that you have like got the first milestone. Then you have already counseled that now we have to see the sac. Then we have a cardiac activity. So the road has begun, right? We have left, the train has left the station one, but we have a long way to go together.
But Dr. Sonali, do you feel that our work is tough? A patient who has conceived after years of treatment, or rather after spending lots of money, she is so happy. Do you think that road is very smooth for her?
No, the road isn't very smooth, because with all the knowledge of higher chances of abortions and higher chances of chromosomal anomalies and everything, we know what is going to come, what problems we are going to face. Though we do not tell the patient on the first go, we know it and we are apprehensive about it.
So, Puri Madam, I am going to ask you, what are the risk factors for this patient?
Most of these patients might be elderly. Maybe they are having an advanced stage pregnancy. That itself is associated with a lot of adverse pregnancy outcomes. Besides that, because of age and other factors, they do have a higher chance of medical problems which might aggravate or may arise during pregnancy. Also, the pregnancy outcomes may suffer because of some techniques which have been used during the procedure. And so the patient does have a lot of risk factors, maybe more than a normal patient who does not have a non-ART pregnancy.
So, I have tried to make a list of all these factors. And if you add even multifetal pregnancy, even if you exclude it also, then when you are comparing this pregnancy with a singleton pregnancy, risk is even higher.
So ART is a very broad terminology, right?
Yeah.
Depends on whether patient has come for the treatment of infertility less than 5 years, within the age limit of 30 years, and is conceived with simple medicines like clomiphene, etc. There may not pose any much difficult problems as compared to a normal pregnancy. But those who are aged, say 35 plus, and have conceived later on with previous histories of so many surgeries and etc., might pose some problems.
Sir, 35 plus people would be offended. I mean, you can't call them aged or 35 plus.
So
we are discussing in context of infertility, for fertility. See, I'm young at 60 also.
Agreed.
So even before patient has become pregnant, would you like to assess all patients who are coming to you for infertility treatment? Some
Yes,
sort of counseling?
It's very essential that each and every patient who is to be given ART should be evaluated properly. That is preconception reassessment and individualized risk should be found out, so that when the patient enters the pregnancy, she has no physical or mental problem, or the problems are well under control, like diabetes, hypertension, and then if she conceives, then the chances of maternal and perinatal complications are less.
So there is a role of evaluation of these patients, because some of them are about 35, some of them are already having some medical problems. And so there is a list of all these factors. Some of them are already evaluated while you are treating this patient for infertility, say for example, tobacco, alcohol, fibroids, adenomyosis, septum, even some of them, there is a long list. But I think prior to IVF treatment, patients should be evaluated for medical illnesses and counsel well. What do you say, madam? Purvi madam?
Certainly, there is no
Yeah.
doubt about it. Even any other patient, more so when we are dealing with such women, we need to evaluate them thoroughly. Even if there are conditions which she isn't aware of, we need to
Yeah, you have to
look
find
into
out.
it, find out, treat them, keep them under control, those conditions, and then venture for ART.
So this is my patient. 50 years, she has come for this is a real case. She has come for IVF treatment. She is a known case of hypertension and diabetes. She is on captopril, 25 milligram. Her diabetes is well controlled with 6 units of Mixtar. Her blood pressure is also controlled. Her weight is 80 kg. Her height is 5 feet 4 inches. Her husband's semen report shows less than 5 millions. How will you proceed?
Who is his physician, sir? No, I tell you, why she is on only tablet captopril? Why she is only on mixed insulin? There are oral medication which are safe even for those who are not thinking of going for pregnancy.
Anyway, sir.
Captopril is a second line drug for
Yeah.
hypertension.
So that is why I have deliberately written captopril. I wanted you to comment on that. So would you like to continue that?
Captopril is definitely has to be stopped before initiating
So,
any ART.
yeah, so the message to be conveyed is some of the patient might be having AC inhibitors. And while patient is coming to us for IVF treatment, we have to stop that drug. There are so many options, right? It should not happen that patient is pregnant and she is taking AC inhibitors. So, okay, fine. But I would like to say that she is a case of over diabetes rather than GDM. That is the thing which I would like to highlight.
Also the age.
Yeah.
50 years old.
Yeah,
So
she's menopausal.
are we encouraging her to conceive or at 50 years? So that's a first
So that
question.
is there I am coming. I am coming to that.
Yeah, sir. But at 50, I think according to the guidelines, at one point you have to tell the patient
95,
that
the total should
we
not
have
be more
to,
than 95.
and also added risk factors of diabetes and hypertension.
So how old is too old for success?
So, sir, according to the guidelines, it's 45 for females and 50 for male.
Nine.
The age for female is 50 and the male is 55.
Would you say no to her? Is it her basic right to conceive?
No, we should explain her all the risks, what she is going to face.
So are there any guidelines in our new ART bill?
Yeah, they have decided the female age as 50 and male as 55.
Okay. So there are two things. One thing, we know that she is likely to have a poor prognosis. So that is why whether we should insist her for treatment or not, that is one. And another thing, whether she is capable to carry a healthy pregnancy and raise a child. Literature has said that 77 years aged woman has conceived after IVF. So again a debate, 50, 54, whatever you say, but 50 with underlying issues that could increase her medical and obstetric risk, say no.
And sir, as for this particular case, she has already loaded with all the medical associated conditions, as in she is not a very good candidate even for outcome and also for the health to her pregnancy itself.
And 55 is total cutoff. Okay. And 55 is a deadline, madam. Above 55, would you say?
Usually there is a, you have to think of fetus also. Usually patient is very this hypertensive, and outcome in this type of the pregnancy is guarded. I had seen one patient of 65 years 2 year back. At 20 weeks there was absent diastolic flow, and we prolonged the pregnancy up to the 24 weeks, and at that time weight was 650 grams and reverse diastolic flow. So ultimately the baby didn't survive, so it was useless. So we have to think of in term of outcome also.
So average age of a woman in India, do you know any data available for her own eggs or for donor eggs? Is there any registry? Is there any data available which will tell us average age of a woman undergoing IVF treatment? There is some scope for the work.
Scope for the work, yeah. The Nari people have started taking the data in which they are expecting the registered centers with ICMR and also the non-registered centers with ICMR. It is totally voluntary data sharing. On that basis, they have a chart, but even that is not, because you never know what has been presented in that data. But that is also, it's like just a publication, but you cannot derive any conclusion on that basis.
So we are talking about advanced maternal age. We are not talking about postmenopausal age, right? What would be the advanced maternal age?
35.
35. Okay, fine. 35. And how advanced maternal age and paternal age affect the outcome of ART pregnancy? I have added paternal also. Maternal we know.
Sir, medically, if we consider the mother's age and the father's age, we know the problems related with the gamete when the embryo we are going to transfer, maybe a PGS, a PGT, and then when the pregnancy starts, then we know in the journey, then you have to rule out all the genetic linked things, and second thing is the effect on the mother's health. And third practical thing would be the age of the mother and father, that is the upbringing of the child. So I think you can just decentralize it and talk on three different things. The effect of the embryo itself giving a genetic material, then practically the mother's journey, embryo causing, like, low birth weight, or if it's a frozen embryo transfer, we know big size babies, it induces PIH, and then mother's additional, yes, gestational diabetes, and then the upbringing.
So these are the risk factors. Everyone knows. Time to conceive is more, loss of pregnancy rate is higher, chromosomal physical abnormality rate is higher, multiple pregnancy rate is also higher, GDM, high blood pressure, and increased rate of cesarean section. About increased paternal age, it might have some effect in the quality of the embryo, but it may not have any effect on the pregnancy outcome in the long run.
If we have like less fertilization, supposing
Yeah.
if we have 12 embryos and 7 have fertilized, the embryologist will like stimulation barabar tha, M2, M1, GV, all fragmented, male factor, So it's like a very bottom line given by the embryologist.
So one thing has been discussed already, that case of severe oligo and azo, prior to IVF treatment, I think karyotyping and genetic testing for male should be offered because of Y microdeletion, cystic fibrosis, and congenital absence of the vas and all this.
Yeah, agreed. That was very wonderfully explained by Dr. Krishnan.
So this is an important message which was given, because we just see through the report and we'll say that, it is just about the borderline, okay, fine. But it's not like that.
Sir, I really beg to differ on the semen analysis report interpretation. WHO 5 people would still not, count kaisa hai, motility, what is the motility, but there is something which is called as morphology. Even if you are having a 40 million count with a 35%, but if morphology is 1%, how far are you going to deliver with IUI or any type? So I think these very basic reports interpretation is very important.
So infertility itself is an independent risk factor for these patients. So again, you consider it less than, not over 50, my patient. Her blood pressure is now controlled. I have changed the antihypertensive drug, sir. We had transferred to blastocyst, and to our surprise, her beta HCG level on day 14, 1200 units. Her LFP is 2nd December 20. Is she pregnant? Yeah, biochemical pregnancy is there. We have already talked about the road of her journey. Would you continue the same antihypertensive drug? Madam, she is on atenolol and amlodipine. Would you like to change?
Sir, I would consider changing to labetalol.
Okay. So this we have discussed. Everyone present here has already said that first trimester is most difficult because, do you agree with this?
Yes.
Everyone, I think, agree with this, that first trimester is most difficult for her. And beta HCG is the strongest evidence of chemical a pregnancy. It is not a evidence of clinical pregnancy. So Purvi madam, when will you say that she is pregnant? When will you announce, yes, now you are pregnant?
When I see a gestational sac on ultrasound.
So ultrasonography is the evidence for her. You can show sac to her also, and then it confirms a gestational sac with yolk sac, with good chorionic reaction, and if possible, with fetal pole and cardiac activity. As a fetal medicine specialist, what would you say? Is this satisfying to you, sir?
Yes.
Okay. But prior to that,
Mostly in very early pregnancy, we see G-sec and yolk-sec. G-sec without yolk-sec is still there is a
8
problem.
millimeter, 8 millimeter size. Would you agree?
After 20 millimeter of size, if we don't see the embryo, then it is problem.
Okay. 16 millimeter?
16 milli.
Because they are very anxious. They are very anxious. Every time they would like to see that cardiac activity. And this is happening day to day. That is why I am asking you.
Still, I go up to 20 millimeters
Okay, fine.
because we have to follow the protocol and guideline.
So, still impending risk of blighted ovum, what you said, might turn out to be missed abortion. Maybe APLA might be playing its role. Still, we have got a lot of other things, like we have not implanted, we have not transferred that embryo, or we might have transferred that embryo in the uterus, but that might be either somewhere, and that may be cornual, interstitial, cervical, or even heterotopic. So this we have discussed. So what is more important is live birth rate rather than a clinical pregnancy. And madam, what are the reasons for pregnancy loss in these patients?
So in IVF pregnancies, mostly the luteal phase defects, that is the lower progesterone levels, would be the important causes for early pregnancy loss. So also the chromosomal abnormalities in the conception could be the other causes.
So Sushma madam, does this miscarriage rate differ with the type of treatment? Frozen cycle, fresh cycle, IVF, ICSI, or does it remain same? Okay.
What is the age of the patient, what therapy has been given, and whether it is a euploid embryo transfer is being done, or ERA test has been done and then the embryos are transferred. So there are so many factors which will decide the miscarriage rate, and I mean, frozen embryo transfers gives better pregnancy rate compared to fresh embryo transfer and all that. Dr. Durga would like to add.
So now we are in era of endoscopic surgeons, entering from ART, gradually changing the field. These are the two.
Once he confirms, then we will act.
Okay. No, this picture will confirm, sir. This
Yes, it's
picture.
a low
May I
line.
tell you that
Yes.
that is the fundus, that is the uterus, and that is the cervix.
Yes.
First picture. Where is the pregnancy?
In cervical region.
Okay.
This first this side.
Will it frighten you? At
Yes,
least it will
yes,
frighten
definitely.
me. Those
Yes,
who have
definitely.
seen it, they feel
But,
that they do not see it again.
But we have to see whether it's a aborting pregnancy or it's a implanted pregnancy. Sometimes what happens, patient is bleeding and sac is in the lower part of the uterus. Then we have to see the vascularity. If vascularity is less, then it's a aborting pregnancy.
Okay.
And if vascularity and chorionic reactions are good, then it's cervical pregnancy.
Suppose this sac is slightly higher. Slightly higher. Not in between. That is not exactly not in the lower part of the endometrial cavity, but slightly higher than this upper part of the cervical canal, slightly extending into the lower part of the endometrial cavity. Do you think that it has possibility to go on? Madam?
You have to wait and watch. Sometimes it's slow implantation as the sac starts growing, but also you have to be careful if the patient has previous CS or something, it could be a scar pregnancy. So that has
This
to be
type
ruled
of the
out.
picture, it's a confirmed diagnosis.
This is confirmed, but I would like to put this sac slightly higher.
Isthmic region, uterine isthmic region. Uterine isthmic region.
Yeah. Has it any chance of going upward? It can create catastrophe anytime. Right. And that one, another one sac is inside the cavity and another sac is inside the tube. That is heterotopic. So, what would you like to offer to this patient?
See,
By
Salpingectomy with continuation of the in vitro pregnancy.
You would like to put
A scope.
that is
Dr. Harish.
yeah.
What about cervical pregnancy? How to manage?
That is something different because you can deliberate on it because of the shortage of time. I am not, because itself is a huge topic.
Usually I manage with methotrexate. I
Even
usually
it can
manage
be-
with methotrexate. Even if methotrexate fails and we have to go for a surgical intervention, the amount of bleeding is very, very less.
Kindly look at these pictures.
In first, it's on an angle because this endometrial myometrial junction is elevated. So first near the cornu, second one is normal. Down picture is not look like angular pregnancy.
So we have got three terminologies: cornual pregnancy, angular pregnancy, and interstitial pregnancy. How will you differentiate all these three? Interstitial we know. Angular also we know, because angular is medial to uterotubal junction. Interstitial is in the interstitial portion of the tube. And I think cornual pregnancy is pregnancy in a case of Mullerian anomaly. Are there any chances of angular pregnancy coming into the endometrial cavity and going to term?
Usually what we have to, many a time wrong diagnosis is given. So first it should be confirmed by 3D analysis. Many a time it's near the cornu, but not inside the cornu. So first diagnosis should be confirmed. If it is in the cornu, then it's a problem.
How ultrasound is going to help us? Because that is a crucial decision.
Yes.
Differentiation between interstitial pregnancy and angular pregnancy.
There is a paper which show that usually in interstitial pregnancy, this junction line is elevated.
Yeah, 5 millimeter.
Biometrial thickness
Yeah,
is also. In early pregnancy, only line is elevated.
The next thing is multiple pregnancy. We know that in comparison to a non-ART pregnancy, incidence of multiple pregnancy is definitely higher with our ART. And if the joy multiplies by 2, then problems also multiply by 2, even 4, not by 2. What do you say? 2 or 4? Sir. And prior to ART era, the incidence of twin pregnancy was less. It has increased with this. Reasons we all know. And what is more important is number of fetuses is the most powerful predictive factor for the outcome. So patient has to be counseled thoroughly. Now, does ART procedure affect the incidence of monozygotic twins? We know that these are dichorionic, diamniotic, 2 embryos have been implanted, 2 sacs are seen, even 2 yolk sacs are seen. But is there any possibility?
Yes, it can divide. Recently, we had seen, Madam knows, 2 embryo were transferred and it becomes 4.
That is right.
It's become 4 and 1 was conjoined.
So especially those methods which deal with altering the zona pellucida, or especially where there is a delayed blastocyst implantation. So something wrong with the cleavage, embryonic division. If the embryonic division occurs within these 3 days delayed, then it is a dichorionic diamniotic. 4 to 8 days MCDA. Above 9 to 12 days, it is MCMA. And above that, conjoined twins. So it is the days of the division, delayed division, that will tell us what type of twin is there. Now, madam, how does the twin pregnancy differ from a singleton pregnancy in terms of maternal and perinatal risks?
Okay, so both maternal and perinatal outcomes are worse as compared to singleton pregnancy. The maternal outcome differs because of a higher risk of morbidity as well as mild to severe morbidities. So the first trimester complaints or ailments are almost double. The patients have a higher chance of abortions, preterm labor, once again placentation issues like placenta previa, gestational hypertensive disorders of pregnancy are more. Also prematurity, low birth weight, IUGR, a lot of problems would be more for the fetus also.
So prematurity, growth problems, and anomalies, all 3 increases.
And if it is a monochorionic pregnancy, then 20% more higher risk of complications.
Do you think with dichorionic pregnancy, is there any increase in the incidence of growth discordancy?
Also, yes, it's there. Many a time we have seen. Recently, we had seen one patient in one fetus 2.4 kg and other fetus 1.4 kg.
Reason may be because of some difference in the placentation, vascularization, or both fetuses may be totally genetically different, and that might be responsible for the difference in the growth. So it is not that IVF both should be same. MCDA we all know that there are all problems of TTTS and everything, but here also discrepancy in the growth can occur. These are all problems, even CP and fetal death rate and major anomaly and aneuploidy. આ શું લાગે સાહેબ? Dr. Bhuvar. Yeah, you are looking from there.
First picture is to show the chorionicity, I think.
Another is a very small, going away now, gradually,
Yes.
gradually going.
Yes,
vanishing.
one fetus is vanishing, yes. Second.
Has it any impact on the outcome?
Usually dichorionic, there is no risk to other fetus.
At what time does it vanish? Suppose it vanishes before 8 weeks. There is no difference in the outcome.
First trimester vanishing occurs, then there is no problem to the second twin, and even maternal complications are also not many. If the vanishing twin occurs during second trimester, then there are complications. But first trimester vanishing, usually apart from just spotting and cramping to the mother, no other complications.
So outcomes are comparable.
Even in second trimester also there is not a much problem. It's occur only third trimester if IUD is in third trimester. But when there is a vanishing twins, we have to be careful in first trimester's aneuploidy screening for doing this biochemistry.
Means we have to follow that patient repeatedly with ultrasound also. And
No, biochemistry cannot be done.
Will not be.
I am coming to that. I am coming to that. I am coming to all policies of biochemical markers. DCDA.
See, vanishing is only, I think it's up to first trimester.
First trimester.
After second trimester, there is one live, one dead fetus.
One dead
may
fetus,
remain. It is not vanishing. Vanishing.
Term
It
vanishing
takes
is
time
for
to
first
vanish.
trimester.
It takes time to vanish. That is what I say. Vanishing means what we have seen is usually in the first trimester. But suppose there is, I would say that suppose there is IUFD. It has to vanish also. One fetus die at around 20 weeks. Then also it is a vanishing. Now, just I said you, is there any increase in the incidence of aneuploidy in twins? Because there is twins, there are higher chances of aneuploidy. Because there is twin pregnancy, there are more chances of Down. What do you say?
No.
Almost same. How do you test in the first trimester?
So there are some papers saying that if it's a ICSI pregnancy, then there are higher chances of aneuploidies in the twins. Only in ICSI cases, not in the other IVFs. Only some papers have said, others have contradicted it. So it's no general consensus yet.
So how do we screen them, sir, for aneuploidy?
For aneuploidy, first of all, we have to ask whether is a donor egg or a patient's egg. That is a first question. Second thing is we usually follow like this normal routine pregnancy, 11 to 14 weeks scan, and do NT scan. NT scan, and we have to counsel about the double marker, NT with double marker. That is a standard protocol in our country, and also we have to counsel about the NIPT, because according to ECOG guideline, NIPT should be offered to all patients. So it should be offered to patient. If patient wants to do it, then okay. Otherwise, NT and double marker is a standard protocol for evaluating aneuploidy in first trimester.
Does biochemical markers are that helpful as they are helpful in singleton?
No, sir. Of course, in twin pregnancy, you will never. The levels are different, and then singleton pregnancy. So NIPT is better option.
How does NIPT, because both the fetuses you are withdrawing blood?
We don't know which fetus.
I just want to know that is why.
For dichorionic pregnancy, if there is a positive, then we have to do the this sample of both the sex. And in monochorionic pregnancy, the risk is same for the each fetus.
In addition to NIPT, other markers, sonographic markers, are they helpful?
Yes, definitely. This NIPT is not an option of NT scan.
Firoz, if the patient is willing directly for NIPT, should we go omit the NT and
No, we cannot omit NT because
it is a
no,
screening
no.
test.
Should not be
I think it is a screening test.
At the time of NT, we can diagnose many anomalies also. So, first trimester anomaly, lethal cardiac anomaly, brain anomalies, limbs abnormalities, spinal, even open spina bifida. That also we can
Actually,
diagnose.
NT scan is a misnomer. It should be early anomaly scan.
Yes, early anomaly scan. And best time to do NT scan is around CRL 55 to 60 because many a time consultant send us patient at 47 CRL. Then only we can do is NT, not anatomy. So better to screen at CRL 57, 58. Optimum is 65. 65 is the best. So we can, it's equal to 18 week scan. NT scan is equal to 18 week scan if it's done at 65 CRL.
Suppose there is a difference of CRL in both the fetuses, difference of almost 10%. What are your comments?
10% is not important. If it is more than 20%, then we have to think in monochorionic twins. Because if we see the difference of more than 20% in CRL, then risk of TTTS is higher.
Okay, so this is an important message. We have to measure CRL carefully of individual fetus, and if there is a difference of more than 20%, that it will tell us that there is something going to be, some sort of, TTTS is likely to occur.
Yes.
Now coming to prematurity. Madam, can you prevent preterm labor?
It's not entirely preventable. Depends on the causes. You may take steps in time so as to reduce the morbidity or perinatal morbidity because of preterm labor, as you've already
I would
mentioned.
like to ask my patient to have a complete bed rest.
That
She
doesn't
should not
prevent-
even get up except, going for washroom. So is it going to be helpful?
That won't be helpful.
I would like ask my patient to restrict her all physical activities and even not to, reduce her work hours and everything.
That's not I was talking about. I was talking about in terms of giving corticosteroids and tocolysis for a short duration in the eventuality she develops preterm contractions.
Okay, so once a patient is in labor, tocolytics may pull on for the corticosteroids to work. That is what you want to say. Twin pregnancy is there, conceived after ARTS. Would you like to offer her circlage prophylactically to all? Prophylactic circlage to all multiple pregnancies.
Sir, I personally do cervical encirclage of ART pregnancy.
Theoretically, everybody says no, but practically everybody is doing.
Practically, I never do. There was an example because I always feel, if the cervical length is fine, everything is absolutely okay. You give a slight higher and longer term dose of progesterone, right? Up till you can continue the project, because I think that it gives another point of infection in the body, and ultimately it's a nitrogenic point you are creating. I had one patient, sir, twins. She had conceived, then she had an abortion. That patient was from Jambu, sir. Then at I think 23 weeks she had an abortion. Her brother came to fight with me ke taka kyun nahi liya. Then her husband was a very understanding person. They again came to me after 2 years. And then this time I decided that I'll go for a set transfer. So on a beautiful blastocyst, she conceived. But in spite of singleton pregnancy, her husband came, Madam, taka le lo is. And then I did.
Taka લીધા હોય પછી બી abort થાય તો same question will be there કેવા કેવા taka લીધા.
But sir, see, that is why sometimes, it is evidence. See, evidence is like, sometimes practically you can modify. But if it is unindicated, I think, some disciplines definitely. There are two schools of thought. Those who follow this follow very rigidly, and those who don't follow, they don't follow it.
If a patient or this twin patient go with pain to other obstetrician, first they will ask, "Taka nathi lida?" And that is a criticism for our colleague also.
So, madam, when will you advise circlet?
As per the guidelines, it is advisable only if the cervical length is less than 2.5 centimeters
At
or
what stage of
25.
gestation?
It start with 16 weeks. You can monitor up to 16 to 22 or 24 weeks.
And beyond which you do not advise.
So,
Beyond the age
do you
of-
need to monitor cervical length throughout? I mean, up to what length of pregnancy?
See, one of the components of doing the 11 to 14 week scan is also taking a cervical length. You take it once, and then when you are doing anomaly scan, you can do it again. That gives you an idea about the baseline cervical length, and then you can decide whether you need to take or not.
Would you like to add another parameter, your clinical examination? On examination, you have palpated, you can, the whole cervix is
Gone
open.
are those days, sir.
Okay, fine. That is what I wanted, sir. So there is a roll-up transvaginal sonography for assessment of length of the cervix, right? Again, see, there are 3 fetuses. Which one will you reduce?
Would you
And
like to
at
say
what
something?
time will you reduce?
In this picture, first we have to determine the chorionicity, whether they are dichorionic twins or monochorionic. Monochorionic we cannot reduce. If triplet is there, one single and one monochorionic pair, it's better to reduce a monochorionic pair rather than the single this fetus. First, there should be a good anatomy scan. Then only reduction should be planned.
At what maturity after aneuploidy testing?
I prefer after CRL 55.
We all know this has been discussed. Risk of IUGR, prematurity, stillbirth, neonatal death increases. Presentation issues, higher rate of placenta previa, abruption, retained placenta, hypertensive disorders, GDM, so many things. So now coming to patient again. Her blood pressure is well controlled. Fortunately, everything went fine. Her ultrasonography showed central placenta previa. There was no anomaly, and she got admitted at around 30 weeks with bout, severe bleeding per vagina. Her blood pressure was still higher. We have admitted this patient. Bleeding is stopped. Now, would you advise her to go home or would you keep her in the hospital? SSG hospital. Madam, placenta previa. Central placenta previa.
We keep admitted.
You keep admitted. You don't allow a case of central placenta previa, 30 weeks pregnancy to go home. Keep admitted. Okay, under observation. Okay, I did the same thing. Because to differ from these people, they are the real teachers, you know, and you can't dare to differ from them.
It's not because you can't dare, because they are right, you can't differ.
So she was admitted, her blood pressure was controlled. Again, she was there. Doppler study showed everything, and then gradually started showing IUGR. Oligo, 34 weeks. Still, are we going to wait? Are we going to wait? The AFI 6, 7.
Usually, Doppler is the only parameter which tell you about the delivery, and not a Leica. Leica is not a parameter on which we should act upon. We have to see the Doppler. How is the Doppler?
What do you say? Would you depend on Doppler only?
Not
Central
only
placenta
Doppler, but I
previa.
think, sir, Doppler would be one of the
Doppler study,
major.
umbilical artery flow is okay.
And depending upon your NICU facility, at what weight you are comfortable, then you can take
She
baby
has
out.
central placenta previa. If she gets
Madam,
another mouth,
are you going to wait or are you going to deliver this patient?
This patient I will definitely want to deliver, because in spite of the Doppler studies being normal, we know central placenta previa is another thing that is intra-op troublesome,
Yeah.
but she has already set in for IUGR. So just prolonging it is not going to do any good to the baby, right? So with steroid, 35 is a very decent age to deliver the baby.
So
Even if there is no central placenta previa, are you going to gain anything more by prolonging the pregnancy?
at 34, 35 weeks, with early IUGR, AFI7, and Doppler within normal range, I would like to wait still 7 to 10 days. Would you
7
agree
to
with
10
me?
days is okay, sir. That is not prolonged. That is not prolongation. True prolongation
But
is
that is
when
why
you
we have kept her
when you
admitted.
take
That is why
take
we
her
have
to
kept her
37 weeks. Otherwise, 5-7 days is okay.
So I would like to go up to 36. 34 is something, less. But I would like to follow this patient every 3 days with Doppler. Doppler will not tell you when to deliver. Doppler will tell you when not to deliver, sir. Doppler will buy time for us, not for this case.
In this type of the patient, usually in setup like Baroda, we prefer to deliver this
Okay,
type of the
fine.
patient. But if there is a no complication, then in this type of the finding, we can still wait up to 37 weeks in singleton or no placenta previa. Not only oligohydramnios is not an indication of delivery.
But message that I would like to carry, that all IVF cases, even if at all, if you want to go for cesarean section, don't end up in emergency cesarean section.
yes.
Yes.
Because with central placenta
Central
previa.
placenta.
Agreed? So 36 weeks, 1.6 kg, AFI gradually slightly reduced. Umbilical artery diastolic flow is reduced. Still there is no absent or reverse flow. MCI is still normal. Ductus venosus is still normal. But then I did not wait. And then we did cesarean section and things went fine. So, Madam Sandhya, would you like to go for cesarean section for all IVF cases?
Most of the times, only if I am very sure that this patient is behaving like any other spontaneous pregnancy without any complications, average weight, only then I would give trial. Most of the times I would not wait.
100% cesarean section, yes or no, sir? IVF.
Don't do C-section.
All cesarean section, yes or no?
He will come only if there is a problem in cesarean section.
What do you say? Madam to naach paadse.
Sir, 100% is a little higher, but I think majority of us do believe, because the patients also demand cesarean
You
section
must
in
have
ART
read that
pregnancies.
11 cesarean section in papers. 15 August, 15 cesarean sections. I have read such type of.
So it is safe to say that the rate of cesarean section is definitely higher in ART pregnancy and the mode of delivery is preferable, but we wouldn't say
Once-
100%.
So not
I had
all
one
cases.
I had one patient, she came at 35, 36 weeks. She never disclosed that she had IVF because when I gave her good trial, she delivered 3 kg baby and all. Then she disclosed that it was IVF pregnancy. I said, if you would have told me before,
But we all agree that she is a high-risk pregnancy. She will require continuous electronic fetal monitoring.
We would.
Agreed. Madam, Purvi madam, do you agree that all patients of IVF, they require electronic fetal monitoring?
Otherwise,
nowadays
also, I
we are
think
anyways
intrapartum
doing
fetal
electronic.
monitoring, yeah. Every
So,
patient,
abhi to
every
sir,
pregnancy
spontaneous
and
also
every
we
patient
do
in labor
continuous. We put the NST.
deserves a intrapartum fetal monitoring.
So are you going to sit there for 6 hours, 8 hours?
Sir, I am doing only cesarean section.
So the message is all IVF pregnancy is no different from a natural one. And the need for cesarean section may arise because of certain complications in pregnancy that may occur even with natural conception and not because she has undergone IVF. Because she has undergone IVF, she should undergo cesarean section. That concept I have seen, I have witnessed, I have observed, I have experienced. But so the odds of delivering by cesarean section are greater. Agreed. Incidence of cesarean section is still of 10 to 12%. It might go up to 30%. But I have seen that 30% is a normal incidence for cesarean section in many centers. Yeah. So there should not be no influence of type of treatment, whether it is IVF, ICSI, embryo transfer on the rate of cesarean section. So we should counsel her about the increased risk of cesarean delivery, though it most of the times what happens, patient will insist કે સાહેબ IVF કરાયેલું છે, આપણે normal delivery કરવાની નથી. How will you counsel these patients? કઈ થવું નહીં જોઈએ.
We will not. We would rather do a cesarean section, sir, if she has asked for it.
So there are some factors which is a patient specific. Some of the patients are that કે બને, I have seen some patients who will not even allow PV examination. PV नहीं करवानी, बस सिद्धू cesarean करवानी. Demand cesarean section. And these patients, they are going to demand. Thank you.
Thank you, Dr. Narendra Gajjar.
Anything my panelists would like to
I would
suggest?
I would like to thank Dr. Narendra sir for taking us, practical things and evidence-based things. So from the entire panelist, I would like to thank him.
I just want excellent panel discussion and very apt and balanced answers were there by all of you. One thing I just wanted to say that with IVF, the consultants or the ART clinics approach is to reduce the risk of antenatal problems and improve the benefits of the antenatal cases so that pregnancy doesn't remain a nightmare, basically. And we can start doing it right from the beginning, that when you choose a patient for IVF, you see that she is fit for IVF, number one. Number two is you see that you go for proper stimulation, so there is no OHSS and other things, and you go for frozen embryo transfer when the risk of OHSS is there. Number two. Number three is that you go for single blastocyst transfer so that the risk of multiple pregnancy, fetal reduction, etc. is eliminated. So life is easy because preterm IUGR, etc. would be more with multifetal pregnancy. So we can avoid it, because such a patient with such a high risk factors, like that was the real case of yours, if we want to hand it over to the obstetrician, well, we are putting them into so much of stress. So all the obstetricians who are receiving ART patients, my question is, are you scared?
No, not scared. Not scared.
That's really a relief, because from our side, we definitely try to minimize. I mean, if the age is slightly bit on a higher side, we take preoperative fitness for the pregnancy. I mean, you cannot give a dictum, but see, there's some very basic guidelines you have to get for yourself also, that if the patient is 38 years, even before she comes for a pickup, then she has to have a physician fitness, and I mean, just rule out few things.
Ma'am, obstetric patients receiving ART patients are not scared, but obstetricians who along with obstetrics do ART, they are scared.
Madam, I want to add.
I would like to comment. Most of the infertility specialists are younger. Let me tell you very frankly. And most of the obstetrics really require some gray hair.
So because I think when you have done the IVF of the patient, been with the patient through infertility, then the 9 months of pregnancy, there is a little bit of element where you want to tread on safer paths and you are scared of vaginal delivery.
Sir, I am scared when this IVF pregnancy for fetus come for reduction of 2 fetus. I am really scared.
Firoz, you have confessed. That's why sometimes you don't answer my phone. It's like, madam, I'm busy. And I think
thank
to the
you want to say something?
I think since everyone is present here, I would like to have a very modest request. I don't know if it's an adequate platform or not, but I think thalassemia, it needs to be a mandatory investigations for any infertility patient, because I mean, at least I have started practicing, because sometimes the female is trait, we don't know about the husband, and then last minute, then if he's positive or Punjabi trait or whatever traits, then the entire scenario of IVF or the patient you are treating is going to change. Thank you. I think Reshmi, thanks for permitting.
Yeah. So thanks, Narendra sir and all the panelists. And I would request Bakshi madam and Durga madam to give the moment of appreciation to Narendra sir. And Dr. Narendra sir will give memento to all the panelists. For Hital, Pela Narendra sir. And then everybody can join for a delicious dinner. So all the panelists can come together, so we'll have a group photograph also. We'll take all the panelists together with the mementos, a single picture.